Bonjour à tous et bienvenue à
Good
ce
afternoon,
colloque Famille et
everyone.
chercheurs.
And first of all,
Merci à l'équipe,
a warm welcome
merci à
to
l'équipe ELA
everyone.
qui a
I would
organisé
like
cet
to thank
événement.
the ELA team for
Merci à tous
organizing.
les interprètes
I would like
qui
to thank the
ont été dans des
interpreters.
conditions de confort quand même
Thank you so much
très
for
favorables.
allowing us to
Et
work
un
in
énorme
such wonderful
merci à tous
conditions. I
les
would also like
intervenants,
to
médecins,
warm all the
scientifiques,
doctors,
chercheurs,
physicians,
qui ont
researchers
consacré votre
for
temps
all
devant
their
nous, bien
the
sûr,
time,
et qui
their
tout au long
precious
de
time,
l'année
and for
étaient
all
là
their hard
patients,
work and
nous les
efforts
patients,
throughout
nous
the
les
year
familles de patients,
for
et
our patient
pour vos efforts aussi pour
community.
faire la lumière sur ces maladies et
Thank you for
trouver des
helping
remèdes.
us work
Alors
and
c'est la
research on
troisième
those diseases
fois que
and
nous
find
organisons
remedies.
le colloque
This is our
en
third family
visioconférence. Les
research
autres
conference
années
organized
ont été en
remotely.
présentiel à
The
Paris.
previous years were
La première
held
fois, évidemment,
face to face.
c'était une fois, on va dire,
So the
c'était une occasion
first
contrainte puisque vous
time
savez qu'il y
we
avait
felt
une pandémie qui nous empêchait tout
it was
déplacement.
because of the
Et
pandemic.
depuis, on
We
a,
couldn't
on
really
s'est rendu
travel,
compte assez
but
vite
it
que
also made
cette
us
formule était particulièrement
realize
adaptée
that it
à
actually worked
permettre à ceux qui ne
really
peuvent
well
malheureusement
and
pas
that
se
it was a great
déplacer pour des
opportunity
raisons de
for those
handicap
who
ou
can't
même tout simplement
travel
pour les
for
événements, eh ben,
various reasons,
d'obtenir quand même,
let
d'accéder
it
quand
be
même à
distance
l'information qui est
alone,
essentielle
to still attend.
pour les
And
familles d'un peu partout en France et dans le monde.
we see it as a real opportunity for families in
Euh,
France and
le
outside of
choix
France
de,
to
de la
attend.
visioconférence donc, est une
So
vraie réussite.
the
En tout cas,
choice
c'est comme
of
ça qu'on le
video
voit aujourd'hui,
conference,
puisque
we think is a
il y a
success.
près de 400
We have
personnes qui se
more
sont
than
inscrites
400
pour
people who
les différents
registered
ateliers du
for
week-end.
the different workshops
Et
organized throughout the weekend.
elles proviennent de 5 continents différents
Participants
et
from
elles représentent
5
27
different
nationalités
continents and
différentes. Donc, c'est
representing a
vraiment
total
un
of
vrai plus pour toutes ces
27
familles qui sont très très loin de
nationalities.
nous. Je ne peux pas
So I think it is a great
donner la distance
opportunity
maximale,
also
mais
for
ça,
families who
ça
are
paraît
listening to us from
évidemment extrêmement loin, mais
abroad and who are
ça ne
very
coûte pas
far.
pour
They're very
assister
far
à
and yet they're very
à
close
ces
because they're
formidable
here, they're
intervention.
attending, they're listening to
Un mot quand
today's
même
and
sur ELA
tomorrow's
International. ELA
presentations. A
International,
quick word about
c'est
ELA
une
International.
association
ELA
ELA en
International
Europe, en Allemagne,
comprises
en
a
Belgique,
total of 7
en Espagne, en
associations in
Italie,
Germany,
Luxembourg,
Belgium,
la
Spain,
Suisse.
France, Italy,
Nous
Luxembourg, and
avons, depuis le
Switzerland.
début de ce
Since
confinement, deux
the
objectifs
beginning,
majeurs.
we've had two
Le
main
premier, c'est de
objectives.
financer la
The
recherche,
first
c'est
one
de
is to fund
soutenir les
research,
scientifiques qui travaillent pour
to support
des solutions
scientific
innovées.
research and scientific
Nous avons investi
programs.
près de 50 millions
We've invested
d'euros
nearly
dans cette
50
recherche
million
disséminée
euros
dans
in
plus de
research so
550
far
programmes de
in more
recherche.
than 550
Et nous
research
espérons évidemment faire
programs,
mieux dans les prochaines
and
années.
we
Nous
hope
invitons d'ailleurs
to do
toutes les
better in the coming
associations
years. As a matter of fact,
ELA qui
we
seraient
can
contributeurs ou
only
pas d'ailleurs,
encourage
qui
and
seraient
urge
présents
all
à ce symposium,
organizations
de
um,
venir conforter cette
to
alliance, ce regroupement,
reinforce
parce que c'est de l'union
our
que naît la
gathering.
force.
We believe that
Le deuxième
by being
objectif
united,
majeur
we're stronger.
de
The
l'ELA
second
International,
main
c'est de
objective of ELA
créer
International
cette
is
communauté de
to
patients
create a
concernés par les
community of
leukodystrophies la plus forte et la
leukodystrophy
plus grande
patients.
possible.
We want a
Et
community that is as strong
pourquoi pas pour le
and
plaisir
broad as
de faire un
possible,
regroupement
not just
maximal,
for the sake of being
la
together
raison, c'est de
and not just for
permettre
the sake of
justement
having big
à vous,
numbers,
les scientifiques, à
but
vous, les chercheurs,
primarily
de
to allow
développer des
you,
connaissances sur les maladies les plus
researchers, to develop
profondes,
knowledge about
sur les formes de
diseases
leukodystrophie moins connues, et de permettre
for all forms of
de
leukodystrophy, the
suivre
ones that are
de
known, the
façon
ones that
très
are less well
qualifiée.
known,
En un
enable
mot,
quality
pour
research,
permettre d'accélérer la
clinical
recherche
trials,
médicale.
simply
Et
to accelerate research.
c'est aussi pour ça qu'on a
And
créé
this is why
ensemble
we
une
designed
plateforme
a platform.
digitale
It's a digital
internationale qui
platform,
s'appelle Le
which is
Connect
truly international, called
et
LuConnect.
qui est réservée aux malades, aux
It
familles
is
malades et à
dedicated
vous aussi,
to
les
patients
chercheurs.
and their
Cette
families, as
plateforme est
well as
conçue
for researchers from all over the
pour
world.
vous. Elle vous
This
permet de
platform was
recevoir les
designed
dernières
for
actualités de la
you.
recherche,
It
pour
provides
vous,
you
les patients
access
ou les
to
familles,
the latest
d'être en
research.
contact avec d'autres
It
familles, ce qui est
is an
important
opportunity
aussi,
for
je
you to
sais,
connect with other families.
en tant que
We
parent
know that
patient
this is
moi-même,
important
c'est très
when,
important
as
d'être
a
en contact
parent
avec
of a
cette autre
patient, I
famille.
know that being in touch
Et
is
puis,
extremely important.
bien sûr,
And
participer,
last
lorsque
but
c'est le
not
cas,
least,
à des études
it
ou
is
à
an
des
opportunity
essais
for us to attend,
Donc, mon
become part
message
of
est le suivant pour toutes
clinical
les familles qui
studies
nous écoutent
and
aujourd'hui
research.
et
So,
demain.
for all those of you who are listening,
Si vous n'avez
all
pas
families
encore
listening, if you have not
connecté, inscrit sur cette plateforme
already
Le Connect, faites-le. Même
connected
si vous ne
or
verrez pas
registered
vos
on
symptômes aujourd'hui,
LeucoConnect,
c'est important
make sure
pour
you do
vous.
so. You may
Même
not
si
think
c'est
it's
pas,
important right
vous n'en
now.
servirez pas tout de suite,
You may
faites-le parce que vous
not be
aurez
sure you will ever
l'impression
use
d'être
it, but
informé
still,
plus vite que
make
les
sure you're
autres.
connected.
Vous
You will
saurez
be
ce qui se
informed
passe
before anyone
et vous
else.
serez
You will
prêt le
be
jour où un
aware of the
programme
very latest
vous demandera
information.
d'initiative.
And if there is a
Donc,
clinical
je vous
trial
en
out
prie,
there, you will be
inscrivez-vous sur
informed also. So please make sure you register going
www.leconnect.com
to www.leconnect.com luconnect.com. In the meantime, well, I'm going to give the floor to Wolfgang Köhler, who's the chairman of this first session on ALD and AMN. To all, a wonderful conference, and see you soon.
Wolfgang, your microphone is off, Dr. Köhler.
Okay, hello to everybody. I think we will have a very nice meeting today, and we will have wonderful speakers here today, giving you a very sophisticated update on what is on for treatments for adrenomyeloneuropathy and adrenoleukodystrophy. So first of all, we start with Isabel Weinhofer from Vienna, Austria. She will present us very recent and very exciting new data on biomarkers. So Isabel, it's your floor.
Oh. So thank you, Wolfgang, and welcome all to my presentation. It's indeed a great pleasure for me to share really here at this ELA meeting directly with the patients and their families our latest research that deals with identifying a blood test that is able to track brain damage in XLD. So in XLD, we believe that mutations in the ABCD1 gene and the accumulation of very long chain fatty acids causes the main disease that is adrenomyeloneuropathy, short AMN. So what happens in AMN is that the long neurons, the motor neurons that are present in the spinal cord, they get issues because of this ABCD1 mutation and the accumulation of the very long chain fatty acids, and they slowly but progressively start to degenerate. And so the patients experience this then as a stiffness in their legs and also experience walking difficulties. So unfortunately, more than half of all XLD patients, they develop a very severe neuroinflammation that we call cerebral ALD. So what happens in CLD, as this cerebral ALD is shortly termed, is that we believe an external or possibly also a genetic trigger initiates a very strong neuroinflammation in the brain of these patients. And so what we understand in neuroinflammation is that microglial cells, which are the brain's innate immune cells, but also astrocytes, which normally help and support nerve cells, they start to get activated. And when they get activated, they will produce very strong and powerful factors, but these factors are also very dangerous, because normally these factors are thought to fight off dangerous situations like a virus or a bacterial infection. However, when this expression of these factors and secretion of these factors proceeds too long, this will be also damaging to other nerves, other brain cell types. For example, these are these endothelial cells that make up the blood-brain barrier, and also of nerve cells. But also the so-called oligodendrocytes that normally enwrap these neurons to make them insulated so the nerve cells can more strongly submit their signals. Also, these oligodendrocytes, they get damaged because of these factors that are secreted by activated microglia and astrocytes. So luckily enough, we have two treatments, and this is the hematopoietic stem cell transplantation and also the gene therapy that are able to halt this severe neuroinflammation that happens in cerebral ALD. But however, both treatments, they have to be carried out really early in the disease course in order to be effective. So how can we detect cerebral ALD in XLD patients? Currently, this is done by MRI. So in this MRI, we also use gadolinium-based contrast agents because normally these contrast agents, they are excluded from the brain. However, if there is a leakiness in the blood-brain barrier, then this gadolinium is also able to infiltrate the brain and is then visualized at these whitish structures within the brain. So it's clear that an MRI is able to detect the onset of cerebral ALD, but unfortunately, MRI is associated with limitations. So it is very difficult with conventional MRIs, as they are normally available in the hospitals, to really quantify the white matter loss and also to get information on the damage of the neurons. And furthermore, especially in the children, these MRIs are very um, burdensome because they often need anesthesia and sedation. So what is really needed is something that would complement or even substitute these MRIs that have to be carried out to detect CLD. So meaning for this, we would need a biomarker that would, as MRI, be able to really detect CLD. So what is a biomarker? A biomarker is a naturally occurring molecule or a characteristic that would be really specifically indicate the presence of a pathological situation or disease. So we in our lab decided to identify such a biomarker for XCLD, and we had lots of discussions on this, and it soon became clear that such a biomarker should be a blood biomarker, because a blood biomarker can be non-invasively collected, very easily collected, and then this blood can be sent to specialized centers where the blood biomarker level could be detected. So our idea would be that then patients would regularly go for blood sampling, and then these blood samples would be sent to specialist centers. Then the biomarker level is measured, and if the level of the biomarker would indicate that an onset of CLD has occurred, then an MRI should be carried out. And if this MRI confirms the onset of CLD, then an immediate treatment should be done, like gene therapy or bone marrow transplantation. So of course, then the question was, but what kind of biomarker could indicate the presence of CLD in XLD patients? And so for this, we had lots of discussion and did a lot of research. And in the end, we decided to directly focus on our nerve cells, because in the end, it's the damage to the nerve cells that determines determines in the end the disability of the patients. So we here decided to directly focus on the neurofilaments, because the neurofilaments, they are almost exclusively expressed in neurons, in our nerve cells. And so normally these neurofilaments, they are super stable and would not leak out into the surrounding brain tissue. However, if a damage occurs, then these neurofilaments would be transported out of the brain and would then also reach the blood. However, in this blood, the levels of neurofilaments, they are super low. And this means that we need a very modern and cutting off technology that is called single molecule array to measure the amounts of NFL in the blood. And the advantage of this methodology is that it's extremely sensitive and also highly reproducible. So we used this methodology and first started off to measure the NFL levels in AMN patients. And this can be seen here in this graph. And as we see here with the AMN patients, we already see a slight but significant increase of NFL in the blood. So this means in the blood already we can see this damage that occurs to the neurons in the spinal cord of AMN patients. However, when we now look at the CLD patients, we see that now the NFL levels, they go really super high up. So this means when CLD occurs, we can see this because of the very high levels of NFL that are present in the blood. And of course, if it was of interest to see whether the levels of NFL would also reflect the severity of the CLD, meaning, or let's say, better say, the stage of CLD. So we decided to correlate the NFL levels with the LER score, and we see that patients that are very advanced already in the CLD course, they have higher levels of NFL when compared to those that are very in the early stages. So these were really interesting findings, but they left us with two open questions. The first one was, the question whether NFL would be powerful and sensitive enough not to only indicate advanced CLD, we see here with this very high blood NFL levels, but if NFL would be sensitive enough also to indicate very early CLD cases when the NFL levels would not be that high. And the second question was whether, if this is indeed the case, would we be able to define a cutoff blood level of NFL that would be able to differentiate between yet asymptomatic XLD patients and early onset CLD patients. So in order to address these questions, it was clear that for this we would need a very large sample set. And that's why we teamed up with many different XLD centers around the world. And in the end, we managed to get really a nicely enlarged, decent sample set that made it possible to target these two questions. And now, because the sample set was that large, we were even able to separate the two groups, which are the children and the adult XLD patients. And so first we set off to verify our old findings. And indeed, also with this new sample set, we found that when it comes to CLD, the NFL levels in the blood, they rise super highly up. But now, because we were able to separate the groups of the adult and the children CLD patients, we found some very interesting thing. Because when we now compare the children CLD patients and the adult CLD patients, we do see that the children, they have much higher NFL levels than the adult CLD patients, despite a similarly scored MRI severity. And we feel that is very interesting because this has previously not been observed. And of course, future research should be targeted to investigate why this is actually the case. Then we moved on and asked the question whether NFL would be sensitive enough to also identify the early stage CLD patients. And for this, we plotted the NFL levels against the age. We see here the children data, and here in green, we see the asymptomatic XLD. In gray, we see the healthy controls, and in black, we see the advanced CLD patients, and in pink, the very early ones. And what we see here is that indeed, NFL was able to nicely separate here these different groups, because we see hardly any overlap between the yet asymptomatic XLD patients and the CLD patients. So indeed, NFL was able to nicely separate the two groups. We just had one asymptomatic patient that was in these levels of CLD patients. And for this one patient, we did a follow-up, and we found that indeed this patient was not that asymptomatic because he had strong psychiatric abnormalities and also adrenal crisis. So these results were very promising. However, when we looked at the adults, we found that NFL in this case here was not that good to separate the different groups, because we see here in green the EMN patients, in gray the healthy controls, and in black the adult CLD patients. And the reason why NFL is not able so nicely separate also the groups in the adults is that, of course, in the adults, we already have this quite high background coming from the AMN phenotype, which is this destruction of nerve cells in the spinal cord. And of course, the levels in the adult CLD patients are not that high. So, but for the children, the data was very promising, and that's why we moved on to identify a cutoff level that would indicate CLD. And meaning would differentiate between CLD patients and asymptomatic patients. And so here I would like to spare you all this very complicated statistical background data, but I would like to show you here this graph where we plotted the NFL levels against the sensitivity, which is the ability to correctly identify CLD, against the specificity, which means that asymptomatic XLD patients would be wrongly identified as CLD. And when we look at this graph and when we go for 100% sensitivity, because we don't want to lose a single CLD patient, was that we found that the cutoff level of 8.3 picogram per ml would be able to distinguish CLD patients from asymptomatic XLD children with 100% sensitivity and an acceptable specificity. For the adults, identifying such a cutoff was rather more difficult, or let's say better, in this case, not possible, because when we also go here for 100% specificity, we would have a very high wrong positive rate. So especially for the adults, we went on to move on to other biomarkers, because the idea was here, maybe we could complement the NFL with other markers and then get a better outcome concerning prediction also in the adults. So we decided also to look at the microglia cells and at the astrocytes. So we started with the astrocytes, but again, also here the same picture emerged. What we found was that also again the children showed up with much higher levels than the adult CLD patients. And this was also reflected when we associated the P levels that come from the astrocytes against the LUS scores. So again, these data reflect what we found with NFL, that the biomarker levels are lower in the adult CLD patients, despite the similar severity of the CLD. And the same was also true when we looked at different cytokines and chemokines that mainly come from microglia astrocytes, but also peripheral immune cells. But here something really interesting popped up that I would like to share with you. Because here we found that indeed the levels were higher in the CLD children when compared to controls, but we found also that quite high levels were already found in yet asymptomatic XCLD children. This was super interesting because this increased level of these pro-inflammatory cytokines and chemokines was not observed when we look at the adults. So there seems again to be some difference between the children and the adults. And we feel that this is very interesting because this increased levels of pro-inflammatory marker expression already in the asymptomatic XCLD children so perfectly aligns with the age of onset that we have for CLD with this peak of onset in childhood. So it was clear when we looked at all these 25 biomarker that we tested during our study that NFL was by far the best of all markers that we tested. And so we did a final validation and just focused directly on NFL. And we were asking our collaboration partner, Toyland, to send us a phenotype blinded sample set. And this phenotype blinded sample set of XCLD children, we decided then we would measure. And just based on the NFL levels and our cutoff of 8.3, we would then classify these samples in coming from CLD patients and coming from asymptomatic controls. And we see, so we did measure these samples. We see them here in this blue color. And based, as I said, on the cutoff, we then classified all that were above the cutoff as CLD and all that were down as yet asymptomatic. And we were very nervous when we received the unblinding, but actually the results were very promising because what we found was that based on this cutoff, we were able to classify 96% of all cases, so 24 out of 25 really correct as being either asymptomatic or being CLD. So there was just one single patient that we wrongly detected as asymptomatic despite having a CLD. And of course, now this is interesting. How come that one single patient between all these 64 measured patients would show up with such low NFL levels? And we are now currently following up this patient and see what is specific about this patient. And what was also interesting that also the other biomarkers that we measured for this patient were quite low. But overall, the results were very promising. And so the next steps we would suggest would be that a regular blood sampling should be done and should be done in parallel to MRI. And then the biomarker, the NFL, should be measured in these blood samples. And then it should be compared to the results coming out of the MRI. And based on this, our proposed data-driven cutoff should be validated and possibly recalibrated. so that in future maybe it could be possible that just based on regular blood sampling, um, a probability for the onset of neuroinflammation could be given to the patients. And if there is a high probability of the onset of neuroinflammation based on the NFL, then the patients would be recommended for MRI. And then as soon as possible, a treatment should be carried out, which is then bone marrow transplantation or gene therapy. So with this, I would like to summarize my message as a take-home message. So we tested a large set of different biomarkers. We tested up to 25 different biomarkers, and from all of them, we found that NFL was by far the best to indicate the presence of CLD in XLD patients. So by using this, our enlarged super nice blood sample set, we defined a cutoff level of 8.3 picogram per ml to correctly identify CLD, which was correctly done for 96% of cases in the validation set. And we had two additional interesting findings. And the first one was that adult CLD presents with significantly lower biomarker levels. And we also had this finding that in yet asymptomatic children that did not yet develop CLD, we found this pro-inflammatory cytokine chemokine profile, which aligns with this peak onset of CLD in childhood. So with this, I'm grateful, of course, to my co-workers, which are Johannes Berger, Sonny Vosbet and Pete Inatsirfus here in Vienna. But I'm also very grateful and to all our collaboration partners that supported us with samples from XLD patients. And with this, I would like to thank you for your attention.
Thank you very much, Isabel, for this very exciting news and the exciting new technique you presented, which will probably reduce the burden of repeating MRIs, especially in children, because they usually need the sedation for this diagnostic procedure, which is, of course, always a critical situation. So thank you again for your talk. I think we will have some questions at the end of this session. And I would like to motivate everybody to use the chat for questions that we probably can answer by the end of this session. So we will now proceed with Lisa Schäfer from my group. She is reporting on clinical symptoms and quality of life in women with adrenal leukodystrophy, a group which is broadly forgotten sometimes. And I'm extremely happy that we had wonderful support from ELA, which was very exciting to use this new platform, the Leukonet platform in the internet, which is indeed a great opportunity for all of you to be part of research and to participate in research projects. So this is extremely important that ELA set up this platform. And Lisa is going to present us first data from our research in women with ALD. Lisa, go ahead.
Yes, thank you very much. I hope you can see my presentation. And many thanks to ELA International for the invitation. I'm pleased to present to you today our studies, which we are currently conducting in Leipzig, Germany, on ALD in women, and first results on the impact of symptomatic causes on the quality of life in women with ALD. So for a long time, it was assumed that women with ALD are pure gene carriers due to the X-linked inheritance and remain asymptomatic their whole lives. And today, however, we know, and also more and more clinical studies show that a large proportion of women with ALD develop symptoms of myeloneuropathy during their lifetime, which mainly presents as gait disorders, sensory impairment in the legs, and bladder and bowel dysfunction. And in contrast to men, Myeloneuropathy in women with AAD progresses slower, usually shows no adrenal insufficiency, and symptomatic courses have a later onset in life, with most women showing signs of myeloneuropathy when they are over 40 years of age. And further, women with AAD have a very low risk of developing cerebral inflammation, as we heard before from Dr. Weinhofer. So a phenotype we call cerebral ALD, and which is often seen in boys and in men with ALD. This is very rare in women with ALD. However, due to the X-linked inheritance, the slower progression rate in women, and the rarity of cerebral ALD, symptomatic women with ALD are often overlooked when it comes to diagnosis and treatment of their symptoms. And sometimes they even are not aware of their symptoms, or health providers don't know that they can get symptoms due to the ALD, although it is X-linked inherited. And further, women with ALD or symptomatic women with ALD are often not considered in research, for example, when testing a new symptomatic treatment, as they are not suitable as study participants due to the slower disease progression compared to men. So this makes it very difficult to measure the effect of a new treatment in an economic time frame. For this reason, we decided some years ago to put women with AAD in focus of research. And since 2019, we have been conducting a study in which we ask women with ALD worldwide if they have symptoms, and if yes, what kind of symptoms they have, and to what extent these affect their quality of life in different areas. And it is also still possible to participate in the study online via the Leuconnect platform, which is hosted by ELA, as we have heard before. And the questionnaires are now available in German, but also in English, French, Italian, and Spanish. And we open, or the study participation is still possible, and the study is open till the end of the year at least. Thus, I would like to use this possibility now to call on all women with ALD who have not yet participated to still take part in the study at Leuconnect, regardless of whether they have symptoms or not. Especially women from Italian and Spanish-speaking countries are very underrepresented so far, with only one person that has participated yet in the Spanish version and none in the Italian version yet. So please feel free, if you haven't taken part in the study yet, to take part. It's just filling out questionnaires, which typically takes 30 up to 45 minutes to complete them, and provide us with valuable information about ALD in women and how we can improve their treatment. These are some results from the study so far. We have been able to evaluate the data of 180 women, and we published these results in an international journal earlier this year. And the 180 women we have interviewed so far were between 18 and 85 years old, and over 71% of the women reported symptoms of myeloneuropathy in self-report. So as you can see on the right side in the figure shows the frequency of symptomatic courses divided by age groups. And as you can see, and as it has been also reported in previous studies, the frequency of symptomatic courses increased by age, with symptoms starting particularly from the age of 40. So in self-report, we also found a prevalence rate of more than 80% for symptomatic courses in women with ALD after the age of 40. However, these results must be interpreted with caution, because we assume that we are overestimating the true frequency of symptomatic courses in women in the general population. Finally, we don't know how many women are in the general population who do not know that they have ALD and remain asymptomatic throughout their life. So they don't develop any myeloneuropathy during their lifetime, but they might even don't know, so they don't take part also in the surveys. And yeah, further results from the study also showed that symptomatic women with ALD reported a decreased quality of life in terms of their physical health. And in addition, 28% of symptomatic women with ALD reached an overall score on the depression questionnaire indicating a clinical depression, which means a depression that severe that it actually needs treatment. And further, from this symptomatic women we've interviewed, 80% reported sleeping disorders, 74% chronic pain, 38% sexual dysfunction, and almost half of the women also reported additionally a restless leg syndrome. And as you can see in this table, compared to asymptomatic women, the frequencies of these mental and physical complaints in symptomatic women with ALD were much higher compared to asymptomatic women. And asymptomatic women with ALD, so women with ALD who don't reported any signs of myeloneuropathy, they also reported frequencies of these mental and physical comorbidities or complaints that high, like the frequencies or like those we found also in the general population. So the frequency, for instance, for depressions is not higher than in healthy controls. Further, our study results showed that symptomatic women with at least one son with ALD reported reduced social participation and mental health compared to symptomatic women who didn't were mothers of a child or boy affected by ALD. So based on these results, we wanted to offer symptomatic women a new multidisciplinary lifestyle intervention that not only focuses on the medical treatment of myeloneuropathy, but also offers social work and psychological support if it is needed. And also we wanted to develop an intervention that shows women with ALD, symptomatic women with ALD, ways to actively counteract the course of the disease through, for instance, regular exercise and an adapted diet. So since May last year, we have been conducting the intervention study SMART ALD, in which we are testing the feasibility and efficacy of a new multidisciplinary lifestyle intervention and its effect on the quality of life of symptomatic women with ALD. This study is funded by ELA International, and we wanted to provide women with symptoms more intensive care on a regular basis for 1 year. So this is kind of an add-on intervention. That means it doesn't replace the recommended visits on in a specialized leukodystrophy center. But between this 1 or 2 years to get a medical checkup, we wanted to offer them counseling and more intensive care. And within SMART ALD, participants can take advantage of medical consultations, but also psychological and social consultations. And additionally, we offer them an individual fitness training in a single setting or in a group setting, and further also a disease-specific nutritional counseling. And all appointments, all consultations take place online via video calls so that participants do not have to come to our outpatient clinic and can participate remotely. So we have included 68 patients from whole Germany and further also some patients from Switzerland and from Austria. And the scope of the counseling and the frequency of the appointments are individually adapted to the needs of each participant. That means that in the beginning, we have a medical evaluation together with the woman, and together with her, we decide which modules of Smart AD she will take part in and how often appointments will take place. So this is very personalized. It is disease specific, as for instance, nutritional counseling is done on the base of the recommendations, how you based on the recommendations how to or based on the AMN diet, and so that they try to avoid very long chain fatty acids, and also it has an easy access as everything is provided online, so that people don't have to come to our center. So as I said, we included 68 participants, and to evaluate the efficacy of this lifestyle intervention, Smart ALD, on the quality of life of participants, we divided all participants into two groups. At the beginning of the study, half of the participants were assigned to an experimental group and received the intervention Smart AED for 12 months. And the other half of the participants were assigned to a control group and a waiting listing control group, which means that they had to wait 6 months. And after this 6 months waiting period, they also received 6 months of Smart AED. And this two group design allows us to identify whether the quality of life differs between the experimental group and the control group. That is, or very important for us, is this assessment point T1, so 6 months after study start. And that is when the experimental group has already received Smart AED for 6 months, while the control group only had received treatment as usual, so not this intensive lifestyle intervention. And as you can see, we have altogether 3 assessment points, T0 at the beginning of the study, T1 6 months after study start, and T2 at the end of the study, so after 12 months. And independent of the group membership, we ask the participants at each assessment point to complete some self-report questionnaires on LoiConnect regarding their quality of life and physical mental well-being. And also at each assessment point, they also receive a medical evaluation, and they are asked to wear a fitness tracker, which we have sent them at the beginning of the study. We asked them to wear this fitness tracker at each assessment point for 4 weeks, and this fitness tracker records their physical activity and sleep quality. So we also want to compare or want to evaluate if the physical activity, for instance, will higher during taking part in this program. Unfortunately, we have already closed recruitment of new participants for the study, and also we have only included women from German-speaking countries. However, if the lifestyle intervention proves successful, we would like to make our program available internationally. And further, as a part of the study, we created or we invented some tools which might be useful even after the study, and we want to make them available to a broader audience. For instance, we have created fitness videos on YouTube in which we try to instruct women with AAD how they can do exercises at home that improve balance, coordination, and strength. And as you can see in each fitness videos, there are two trainers, and on the left side, that's Ronja. She's showing the same exercises in the sitting position. So we also try to adapt the fitness training to the different levels of fitness and disabilities of our patients. And hopefully we can do some more videos and put it on this channel and also translate them in different languages to make these available to a broader audience. So this is a short summary what we are doing right now. I want to thank very much ELA for funding our studies, and I also want to give a big thank you to all the participants who help us to do this research, who take part in this research. And again, if you haven't taken part in this quality of life survey yet on LeuConnect, please get registered in LeuConnect and help us to also improve the treatment, especially in women with ALD. Thank you.
Yeah, thank you very much, Lisa, for this very important work. I think it is showing that also women had substantial disease burden in ALD. So this should be addressed more intensively than previously. So this is very important information that you gave us. Thank you very much for the moment. Excuse me, but because I catch the flu yesterday, so I'm a bit of sore throat. Sorry. We our next speaker is Florian Eichler. Florian Eichler is, as you all know, one of the most renowned expert in ALD. And I think we are very happy to have him here at this meeting, at least in a video, as I heard. So he is here to report on treatments for adults with ALD. Interesting title, one size does not fit all. So let's see what he has to say in his video. Elise, can you start this?
PI trial. Hello, delighted to join the ELA family meeting, and sorry I can't be there live, but it's recording.
We don't hear it or not?
Now I can't hear anything. I see the slides.
Can you hear the recording?
No. No.
I apologize. I'm going to try to start again, and hopefully I can get the sound. I'm not sure why there is no sound here. Give me a moment, please. Where could I found?
Do you hear me?
Yes.
Yeah, just before sharing a
Yes.
video, you have a little square to fill, and that means that you can see if you want to share the sound or not, just before sharing.
Okay, let me share. Oh, yes, thank you. Thank you, I found it. Woohoo! So that might work better this time around. Let me try again. Sharing with the sound. Here we go. I'll try it.
Hello, I'm delighted to join this ELA family meeting, and sorry I can't be there live, but this recording should serve the purpose. I'm going to be speaking on treatments for adults with adrenoleukodystrophy. One size does not fit all. Here are my disclosures. I am a PI of various trials and consultant to several companies, importantly also founder of Swan Biotherapeutics. So the pathology of adrenoleukodystrophy differs across various different stages of adrenoleukodystrophy. Importantly, children are born with a gene defect of elevations of very long-chain fatty acids. About 30 to 40% of boys then develop cerebral ALD. If this does not occur, they go on into adulthood and are most likely to prone to spinal cord axonopathy, known as adrenomyeloneuropathy. But 20% of adult men still remain susceptible to adult cerebral ALD. Importantly, these pathologies of the spinal cord and the brain differ, and we need to understand how to properly target treatments to these differences in pathology. Beyond men, it is important that women can also be affected, and not all women with ALD are affected the same way. While many women have a myelopathy similar to what is seen in men, there are also women who have a more prominent neuropathy or small fiber neuropathy, as well as more recently we've discovered that a lot of women suffer from movement disorders. So one size does not fit all. Part of my talk today is to emphasize that both in men as well as in women, there are various different pathologies. In men, we know that adrenal insufficiency can be life-threatening. Adult cerebral ALD can occur in about 20% of adults, and adrenomyeloneuropathy is the most common manifestation that leads to gait and balance difficulties. In women with ALD, we know that a myelopathy similar to what we see in men can occur, but beyond that, they can have a more prominent small fiber neuropathy, and there are differences in manifestation in terms of bowel and bladder dysfunction. We also know that vascular insufficiency can cause significant harm, and it may be independent from the myelopathy and neuropathy, and movement disorders I will also describe in more detail. So here the dreaded pathology we see in the brain of boys and men. This is an inflammatory demyelinating disease that occurs in a zonal pathology, with often the core of the lesion showing marked necrosis, and beyond that in zones C and B we see an inflammatory component that is predominantly perivascular, and then in the outer regions of this there's a zone of microglial cell death that has given rise to our understanding of how to rescue this with bone marrow transplantation and more recently ex vivo gene therapy. Different from that, the adrenomyeloneuropathy of the spinal cord. This is a disease that is non-inflammatory and affects the long tracts of the dorsal columns as well as the corticospinal tracts. So inflammation either coming from the muscles and proprioceptive neurons up into the spine, or information being sent down from the upper motor neuron down to through the corticospinal tract, affecting here both gait and balance as we need to understand our position in space. Movement disorders in women have been found to occur even in the absence of overt brain MRI lesions. These are predominantly tremor, dystonia, but also speech abnormalities. And we've known for many decades that there have been descriptions of torticollis, head tilt, neck tilt, but only recently has this come to full attention in women. So the first step in discussing treatments is that we need to optimize care by emphasizing the importance of regular checkups and monitoring. We need to tailor treatments to symptoms using antispasmodics and analgesics as necessary. Medications for bowel and bladder dysmotility are used. We need to maintain mobility and exercise. Psychosocial well-being is hugely important, and understanding risk-benefit of each approach is critical. We've been analyzing the experiences of women in greater detail at MGH, understanding that both balance difficulties, walking difficulties lead to falls and injuries and fractures, while there are other components such as restless leg that contribute to sleep difficulties, all of this worsening neurologic symptoms and also contributing to depression and anxiety. So here briefly outlined how these manifestations occur across the lifetime. We know that the risk for cerebral ALD is highest in childhood, but still persists in adulthood. Men develop adrenal myeloneuropathy. Women do this about 10 to 15 years later as well. And men are also prone to adrenal insufficiency that we do not see in women. So treatment needs to be targeted to the different manifestations, and strategies to combat inflammation oxidative stress have long been proposed by Aurora Pujol and others in the field of basic sciences, and the use of certain compounds that are anti-inflammatory in nature, but also can alleviate oxidative stress have been used. In particular, multi-center trial of lariglitazone that was conducted to address adrenal myeloneuropathy, but showed a signal that indicates that it might be able to help for adult cerebral ALD patients. And we now in the US have a multi-center randomized placebo-controlled phase 3 trial that is now with adaptive duration in planning. We know that hematopoietic stem cell transplantation in adults with ALD can be effective if used in the early stages, and in those cases where adrenal myeloneuropathy is not a hindrance, meaning that we do not have corticospinal tract involvement, the EDSS that indicates the level of gait difficulties is not beyond the level of 6. And in those cases, it is possible to perform a hematopoietic stem cell transplantation without greater complications, and Wolfgang Köhler has been really pioneering this work and pointing to opportunities here to halt adult cerebral ALD appropriately. Importantly, this is not a treatment for adrenal myeloneuropathy. This is a treatment for adult cerebral ALD. We know that in boys, ex vivo gene therapy has been successful in halting disease progression, and eliminates the need for an allogeneic donor and the risks of graft versus host disease or graft failure. But there are recent challenges recognized in the form of myelodysplasia. Sadly, also there are geographic and socioeconomic disparities, and this treatment has not been implemented in Europe, much to the chagrin of many of us investigators. Beyond the ex vivo gene therapy, I'm going to briefly talk about in vivo gene therapy that is also being pursued for adults with adrenal leukodystrophy. This is an AV-mediated approach that targets the spinal cord. We know that targeting the spinal cord here and delivering a copy of ABCD1 packaged into an AV9 can successfully be delivered to critical spinal cord cells, whether those be the oligodendrocytes or the astrocytes, and provide important support to the ailing axons. It also reduces the very long chain fatty acids, as shown in recent publications here. So there is now a trial currently underway at UMass in Massachusetts, where AV9 delivery of ABCD1 occurs through an osmotic pump with infusion into the intrathecal space over a several hour period. And this is known, at least in mice and non-human primates, to deliver very nicely into the dorsal columns. We're excited about this collaboration at UMass Worcester that is currently underway. As I mentioned before, leg discomfort in women is multifactorial. It can encompass neuropathy, vascular insufficiency, spasticity, as well as restless leg syndrome. And one has to carefully dissect all these individual components. We know that many different medications are used by women with ALD, whether those be pain medications, depression, anxiety meds, antispasmodics, and other medications. But the true efficacy of this has not been systematically studied. And this is something we are currently doing in our cohort. Other management strategies used by women with ALD encompass also surgical interventions that are sought out in about 40% of women for complications related to ALD. Close to 30% of women had steroid injections for pain management. About 22% underwent Botox injections for spasticity. And there's a true knowledge gap here in understanding what interventions and management strategies are most effective. Important to emphasize that many women suffer from small fiber neuropathy that is most evident in swelling of the legs and discoloration of the feet with poor capillary refill, a lot of pain. In some cases where we've performed skin biopsies, we've seen a loss of small fibers, indicating this small fiber neuropathy. And a group from Norway performed a study in small fiber neuropathy in adults with ALD and found that among 8 of the women enrolled in this small study, there were at least 5 of them who had neurophysiologic signs of a small fiber neuropathy. We've recently come to recognize that restless leg syndrome plays a role in several of our female patients with ALD. Restless leg syndrome is defined as the constellation of uncontrollable urge to move legs, sensation of crawling, creeping, throbbing, itching sensation. Often this occurs in the evening when sitting or lying down, and moving eases the unpleasant feeling temporarily. You can see here a brief video of what this looks like in the evening when sleeping or lying down. There's this urge to move that occurs and often disrupts sleep. The pilot study of 32 patients, we found that about 40% of these adults with ALD experience restless leg syndrome. Among females, it was more common than in males, with about 48% of the women affected. Prevalence seems hence substantially higher than that in the general adult population, where prevalence is only 5 to 10%. So we wonder right now whether this is due to certain spinal pathways contributing to RLS. Is currently not yet clear, but we're currently undertaking a trial design for women with ALD in order to investigate this more closely. There's a 2-phase protocol underway, one with screening for symptoms of leg discomfort, and then in the case of a positive readout for restless leg syndrome, randomization to pramipexole or placebo, and then after further period, there is then a washout and then crossover to placebo and pramipexole. So in summary, in adult ALD, there are multiple different pathologies, and there are hence multiple different therapeutic targets that are necessary to address as the physician investigator. These range from brain to spinal cord to peripheral nerve to the very smallest small fiber neuropathy. And we've beyond that also recognized that in women there are certain cortical connectivity networks that might be at play that are also contributing to movement disorders that could be appropriately targeted and help relieve symptoms and improve gait and balance over time. So I want to thank the many people who've contributed over the years to the work we've pursued as Mass General, and I hope that you can email me with any questions. My email is feicchler@partners.org. Thanks for letting me contribute. Take care.
Yeah, thank you very much, and a lot of greetings to Florian. Hopefully he's getting better soon, and thank you for this wonderful update on recent therapies, especially on restless leg syndrome, which I think is very important for many of the women, especially, and of course for the update in gene therapy, even in adrenal neuropathy, which is a great hope for many patients. So I will proceed. Okay. Is it visible?
Not yet. Yes, almost. If you'd like to present it as a slideshow.
Can I do it this way? And
sure.
Yeah, okay. So I would like to proceed with some discussion on further treatments, especially lessons that we learned from this very first international controlled clinical trial in liraglutide in men with adrenal neuropathy. I think I think this is really a milestone that we have been able to have this whole consortium of very decent research centers from all over the world. You can see here sites from US, UK, Netherlands, Italy, Spain, France, Hungary, and Germany to perform this first double-blind, placebo-controlled trial in AMN patients. So AMN is still a rare disease, and it's always very difficult to have trials like this in a controlled way in rare diseases. But this first, and this is the first lesson that we can learn from this study is that it is possible to have such a trial once we are able to cooperate within the centers of excellence, but also it is important to have a strong partner in the industry because such trials are extremely expensive. And of course, we need a partner for the financing of such a trial, and a partner who is taking the risk that such a trial also may have not the wished outcome, the wished result. So you never know when you start with a trial. So, but you still have to invest multi-millions to make such a trial possible. As you can see here, it is a 2-year trial, a double-blind treatment with lariclitazone. And of course, everybody was asking, why lariclitazone? What is that lariclitazone? What's that kind of drugs? So we had some preclinical data on animals and lab data, which are summarized on this on this slide here, which you can also read this in this paper. And these preclinical data, not in humans, but in animals, show that lariclitazone has some neuroprotective effects. You see dose-dependent a reduction of neuroinflammation, for example. You can see normalization of biomarkers, for example, biomarkers Isabel was talking about. You can see a recovery of mitochondrial functions. Mitochondria are the energy organelles in our body, um, which once they are diseased cause severe oxidative stress, which is then harmful in addition to the metabolic defect that we can see in this disease in terms of elevated very long chain fatty acids. So I summarize this more in the picture here in this slide. So we know from this preclinical study that this lariclitazone, which is a PPR gamma agonist, shows a lot of positive effects which are important in the pathogenesis of XALD. For example, reducing inflammation, enabling remyelination, preventing from axonal degeneration, and reducing oxidative stress and mitochondrial dysfunction. So it was from preclinical point of view, it was very promising to use this drug, to test this drug, and that's what was happening. The second point I want to make is, how can we measure if a drug that we want to use in a clinical trial is helpful, is really beneficial? How can we measure this? And in our study, we we used the 6-minute walking test as the primary outcome to measure the efficacy of lariclitazone. I was always very unhappy with the 6-minute walking test for some reason. Yeah, from my experience in many patients with AMN over the many years that I'm taking care of these families, I know that you know that either that patients who are still able to walk, for example, without any walking aid, they are very ambitious to stay at walk, to have their training, to walk as long as they can. But the more the symptoms progress to near wheelchair or using walking aids, those patients, they don't want to walk anymore, because it's very it's not easy to walk in this situation. So there may be a difference in between a patient group of AMN, of those patients who are early in the disease process versus the patients who are late in the disease progress. So this is not an optimal endpoint, but we still have to use this because the authorities say, well, this should be the endpoint on this study. But there are, of course, there are other endpoints that are maybe more important, especially in AMN patients. For example, balance problems. Yeah, everybody who is involved with AMN knows that balance problems are of great importance. Balance problems, even though there's no paralysis or no weakness in the muscle in the legs, but the balance problems cause the need of using a walking aid, for example. And there are also measures like this balance plate here, that you can see here in the picture, where you can measure balance with eyes closed, with eyes open. And everybody who has the AME knows that it's extremely difficult to stand with feet together and eyes closed, just standing, because there's a sway coming up and then there's the risk of falling down. So balance problems are very important. But so we use this as a secondary endpoint and many other secondary endpoints, including MRI endpoints. So here again, I want to emphasize that balance is really something that emerges as an objective, sensitive, and clinically relevant endpoint in terms of functional impairment and quality of life in AMN patients, because this is something that is probably impaired early in the disease process. So when it comes to the results, and this is again something that we have to learn from this study, we have to recognize that in looking at the primary endpoint, which is here on the left side for all patients, there is no meaningful difference in the 6-minute walking test, whether you take the drug or just take the placebo. So this was a bit disappointing because the primary endpoint in this study was negative. But a closer look to the data shows that patients who are using the drug, as you can see here, in different stages of the disease process, having disease for 5 years, for 10 years, for 15 years, or 20 years, it doesn't matter at all. So all patients who are using the drug keep completely stable over the study period of 2 years, which is obviously not the case, and which is stage dependent in the patients who did not receive the drug, which received the placebo. What you can see here, that there is a tremendous difference in patient group who are in the first 5 years of the disease, so early in the disease process. There's a severe deterioration using the placebo over 2 years versus a stabilization of those who received the drug. And this effect, this difference between placebo and drug receiving group is getting less and less and less the longer the patients are already diseased. So maybe, so this is not something that we can really decide on, yes, but there's the idea that the drug, that larotrectinone, has a stage-dependent axonal protective effect. So in other words, it obviously most likely makes much more sense to take this drug as early as possible in the disease process. And the longer the disease process is ongoing, the effect is fading away. So this is, of course, a second lesson that we learned, that choosing the right endpoint could be very crucial for a study outcome. In our case, if we choose the endpoint 6-minute walking test in all patients, we see no difference if we look at all patients. So we have to look at separate patient groups, but this was not predefined, so the study is per se negative. Another point was very important. What came out of this study is that we noticed that patients who are received larotrectinone did not proceed, did not develop a progressive cerebral ALD, which happens in up to 60% of all patients over time, that even in adulthood, the disease may progress from a myelopathic variant of the disease, which we call adrenomyeloneuropathy, to a cerebral inflammatory disease, which is life-threatening and which causes totally different treatment strategies. So this is very harmful to get the cerebral involvement. And what we see, at least in these 2 years, there's not a single patient from the 77 patients who received the lariglutasone who progressed to cerebral ALD, but we have seen 6 from out of 39 patients in the placebo group that proceeds to this life-threatening event. So there's another open question. Is lariglutasone probably preventive from cerebral inflammatory demyelination? So this is an extremely important question, which is currently, as Florian Eichler already mentioned, under discussion, and there will be further studies be necessary to answer this question. So in summary from this lariglutasone study, we can say that this is the first controlled clinical trial, and it is very helpful that internationally treatment centers will work together, will cooperate to achieve results in a common sense. Yeah. But we have to think of a good primary endpoint. So in our study, there was no effect on our primary endpoint. So there should be probably other endpoints which are more informative in terms of a treatment effect in other treatments that are under discussion. So we have also seen very positive effects in this study. We have seen positive treatment effects on body sway and balance, but also on other neurological functions, which are measured by the so-called EDSS, which is a measure which is usually used in multiple sclerosis patients, which is also including cortical spinal cord functions, resulting in a better rating in clinical global impression, both from treating physicians and patients. We have seen, nothing said about this yet, but we have seen that there's a very modest dropout rate. So the drug is obviously well tolerated with not so much side effects. Of course, there are side effects, but this is a different talk. And we see that these clinical effects, these positive clinical effects, are correlated with biomarkers that we tested in this study. So biomarkers similar to what Isabel was talking about. So we see restoring or reduction of harmful biomarkers under treatment with lariglutasone. And most importantly, and finally, the MRI results are very in favor of the active treatment. So we saw only in patients with the placebo arm a progression to inflammatory brain lesions. So this is something that should be followed further. So the question is finally, what are the consequences from this study for our current therapeutic strategy in adrenoleukodystrophy and AMN? So I summarized in this slide our current available therapies in XALD. And as you can see, of course, we have symptomatic treatments which are very helpful, for example, to treat restless leg syndrome or to treat pain or spasticity. We have the chance to normalize long-chain fatty acids because this is an inborn error of metabolism. But normalization of very long-chain fatty acids, for example, with diet or with Lorenzo's oil or other strategies, is not fully preventive, as we know, but it may slow down the clinical progression. So I'm absolutely convinced that this is kind of a basic therapy for all patients. We had other therapies who are not helpful. For example, high-dose biotin was not helpful. The antioxidant treatments probably are not that helpful than expected previously. And of course, we have the stem cell therapy in children and in adults that at least gives us results for at least half of the patients who remained stable with their clinical status in cognition and also in motor functions over time. And we have a long-term survival rate of 70 to 80%. So, but still, there are, as you can see here from this table, there are a lot of unmet needs present. And for example, um, yeah, we need more treatments for the correction of the inborn error of metabolism, to target elevated long chain fatty acids and to normalize long chain fatty acids. Of course, we have the Lorenz's oil, but there are other treatments out there which needs to be tested in clinical trials. Um, I will not explain in detail all these treatments, but there are treatments out there. We need treatments for the recovery of mitochondrial function and oxidative stress. Again, lariglutasone may have an effect on the mitochondrial dysfunction and oxidative stress. We have data on this from the lariglutasone study. So this is, again, a lesson that we have learned out of this study, but other treatments needs to be tested, as indicated here, for example, DNAC, and acetylcysteine, which needs to be tested in clinical trials. Of course, we have the, I've mentioned this already, the prevention from the axonal degeneration, which most likely is stage dependent. So it probably makes sense to use lariglutasone as early as possible to prevent from further myelopathic symptoms. Um, so this is something that is new. We can add this, hopefully add this to the therapy. This is currently under discussion in the authorities, both in the US and in the EU. And we hope that this treatment will be available for all AMN patients soon. Of course, we need new strategies to stop neuroinflammation and repair the defective immunity in this disease. We have a strategy with the stem cell therapy to in an early cerebral involvement to stop this cerebral involvement, to stop this inflammation by stem cell therapy or by gene therapy. But some patients are obviously too progressed for this kind of diseases, for this kind of treatments, and maybe lariglutasone again is able to alter the inflammatory demyelination in the brain. So this is something which is open, which needs to be tested in clinical trials, which are ongoing currently, both in children and adults. And of course, what we wish is to stop the neuroinflammation and even have an anti-inflammatory strategy. We probably can use lariglutasone for this purpose, because I already said to you that we have seen only patients yet in the placebo arm showing progression to adulthood cerebral ALD, and which is not the case in early treatment with lariglutasone. And finally, of course, we wish to improve the myelin defect. We wish to have a remyelinating treatment strategy, addressing the axonal degeneration with a regenerating disease treatment. So this is clearly an unmet need, and possibly, as already mentioned by Florian Eichler, the new gene therapy for AMN patient with an intrathecal approach will give us here some more results in the near future. So what lessons do we have from all these treatments? first of all, it's very exciting that results from preclinical experiments in mice cannot be transferred one-to-one into humans. We know that, but so a pre-selection of meaningful outcome parameters is very crucial for any kinds of new studies that are coming up. But it's exciting that control studies are possible, also for rare diseases. And this is, in my eyes, only possible if we work together in an international cooperation in research centers for ALD. And of course, we need strong financial partners to support such kinds of clinical research. There are a lot of new treatments coming up, and these treatments needed to be addressed in AMN in clinical trials. So this is something that is our work for the next years, and I think that I'm very optimistic that there are new treatments will come beside the treatment with laroquitosone. I hope this will also be a treatment available for all AMN patients, because laroquitosone is obviously very promising drug, especially in early stages of the AMN progression. It's potentially preventive from cerebral inflammatory conversion, but still further studies, especially in cerebral ALD patients, both in childhood and adulthood, are necessary to answer us the open question. So I thank you very much for listening and waiting for your questions. Thank you very much. So can I go further?
Yes, we have one more speaker.
Yeah, we have, yes, we have one more speaker. It's Elise Yazbek from France. So it's a home play for her. And I think that's important and to know if laroquitosone also is helpful in childhood cerebral ALD. And Elise will probably give us some update on this new results coming up.
Yes, hello everyone. I am just sharing my screen and you will tell me if it's working.
Yes, it is.
Okay, so thank you, Ella, for inviting me. I am sorry for the English speakers, but my talk will be in French. I can answer questions in English if you would like to.
Elise, can you enlarge the screen?
Yes, I will.
Okay.
Also, Dr. Yazbek, if you speak French, please use the French channel for interpretation.
So how can I use it?
En bas de votre écran, il y a une petite planète avec.
At the bottom of your screen, there is a little globe that says interpretation.
Sur mon écran, je vois juste ma présentation.
On my screen, I can only see my presentation.
Appuyez sur échapper.
You can exit out, and then you should be able to see Zoom and the little globe at the bottom. There's a language channel for interpretation. So let me unshare and then reshare my presentation. So before sharing your screen, at the bottom of the screen, you should have raise your hand, interpretation, the participants. This is where you also turn on and off your mic.
Avez-vous quitté le partage d'écran?
Have you stopped sharing your screen? Okay, then stop sharing your screen. At the bottom, you should see a little globe that says interpretation. So you can either just set it to French or listen to no translation at all, because otherwise there could be issues with the audio. So the best for you, if you are speaking French, is to listen to the French,
Donc j'ai
because
coché français, ça vous va?
Zoom considers that you are listening to the language that you are speaking, and then you can also have to reply to the
D'accord.
and to
D'accord.
questions
Donc
in
j'ai coché
French.
français et je
Otherwise,
repartage mon
the
écran.
two voices in French and English will be heard at the same
Ok.
time on Zoom. Okay, thank you very much.
Alors, moi, je vais vous parler des
So
enfants
today
et
I
des
will be
garçons qui sont
talking
porteurs
about
d'une
children
adrénoleucodystrophie
in
et donc de l'effet
boys that
numérique chez
have
l'enfant. En
ALD,
faisant
and I
tout
will be
d'abord
talking about the
quelques
Menorix
rappels
clinical
sur la
trial
maladie en
in
elle-même.
children,
Vous
and I
savez
will
déjà que
begin with a
l'adrénoleucodystrophie, c'est une
little
maladie
summary about the
génétique
disease.
qui
So
est
you all
liée
know
au
that
chromosome
X-linked
X. Et
ALD
parmi les
is a
leucodystrophies qui
genetic
sont des
disease. It is
maladies très
to
rares,
the
ça
X
reste la plus fréquente
chromosome,
avec en moyenne
and
une naissance sur
out of
20
all
000.
leukodystrophies, it is
C'est
the
une
most
maladie qui
common
est très
one.
particulière parce
Although
qu'elle
they are
atteint
rare
plusieurs
diseases, it
types,
affects
en
one birth out of
particulier chez
20,000.
les garçons
It
et
is
les hommes
quite a
atteints. Elle
specific
peut concerner
disease
à la
because
fois
it
le
affects different
cerveau,
parts
la
of the
moelle épinière,
body.
les nerfs
It can affect
périphériques,
the
mais aussi
brain, the spinal
des glandes
cord, the peripheral
périphériques
nerves, but
pour les
also
surrénales
the
et les
adrenal
testicules,
glands
alors
and
que
the
chez les
testicles
femmes,
in men.
les seuls
And in
organes atteints
women,
sont
the
donc la moelle
only
épinière et
organs
le
that are
nerf
affected are
périphérique,
the
comme on l'a
spinal
déjà dit.
cord and peripheral
Donc c'est une
nerves, as
maladie
we have
génétique
said.
qui est
So
portée
it
par
is
le
a
chromosome
genetic
X, qui est un
disease
chromosome
that
sexuel
is linked to
et
the
qui
X
concerne un gène
chromosome,
en particulier
which is a sexual
sur ce
chromosome.
chromosome, qui est le gène
And it
ABCD1,
affects one
qui est
gene on that
très
chromosome,
important
which is
puisque
the
quand il est muté,
ABCD1
donc
gene.
anormal,
And it is
il entraîne une
key because when
accumulation
it
anormale d'acides
mutates, when it
gras
is
à très longue
abnormal,
chaîne
it
qui
leads to
donne
an
la
accumulation of
maladie.
very long chain
Et
fatty
ces acides
acids,
gras à très
and
longue
this
chaîne,
leads
c'est un
to the
marqueur
disease. And
biochimique qui est
these
toujours
very
élevé
long
chez les
chain fatty
garçons et les
acids
hommes
are
atteints,
a chemical
estimé
biomarker that is
élevé
always
chez les
very
femmes
high in
productrices
men,
que dans 75 à
and
80%
that
des cas,
is
chez les
high
garçons,
in
c'est toujours
women
comme
and
ça,
only
même l'étude
75 to
génétique.
80% of
Donc là,
women,
c'est juste
which
un
is why
petit
genetic
rappel.
studies are key.
Comme
This was just
c'est le
a quick
chromosome X qui est porteur de
reminder. So
l'anomalie,
because
quand on
the
est une
chromosome
femme
X is the
atteinte,
one carrying
à
the
chaque
disease when you're a
grossesse,
woman,
que ce soit
um,
un petit bébé
every
garçon
time
ou
you fall
fille,
pregnant,
il y a un
whether you
risque
have
de
a
1
boy
sur
or a
2 de
girl, there is a
transmettre la
risk
maladie.
of 1 out of
Alors que
2
quand on est
to
un
pass
homme
on the disease.
atteint,
And when you are
on ne
a
peut
male that's a
transmettre ce
carrier,
chromosome
you
X
can
que à une
only
fille.
um,
Donc un homme atteint
pass on your
aura
X
toujours
chromosome
des
to
filles
your
atteintes
to
de la
baby
maladie, mais
girls.
aucun de
So
ces garçons ne peut ne pas
a man
avoir
carrying
cette
the
maladie.
disease will always pass it on
Alors,
to
un petit
his
rappel sur la
baby
physiopathologie qui
girl,
a
but
déjà
not to
été
baby boys.
discuté. Ce gène
So
ABCD1, il
this
code pour une
gene
protéine très importante qui
ABCD1
est là, la
codes for a
protéine
very
ALD.
important
Et dans
protein,
un
which is the
petit
ALD
organelle de la
protein,
cellule
which
qu'on
is
appelle le
situated
peroxysome.
in
Et
a
c'est
very
un
important
organelle qui est très
organite, which
important
is the
parce qu'en gros, il
peroxisome.
fait le
And
ménage
it is
et il permet de
key because
dégrader
it
beaucoup de
basically
composés
cleans up
toxiques
and it
dans les cellules, en particulier les
eliminates
acides gras à très
toxic
longue chaîne. Et
components
quand cette
such as
protéine,
very
en
long
fait, est
chain fatty
dysfonctionnelle,
acids.
le
And when
tri
this
en fait
protein
des
is
acides gras à très longue chaîne
dysfunctional,
ne se fait pas.
then
Donc, ils
the
s'accumulent dans la cellule
very long
et
chain fatty
deviennent
acids are not
complètement toxiques, entraînant
eliminated, and
justement
they stay in the
cette
cell and become
leucodystrophie qui
toxic.
d'abord
And this
démyélinise,
leads
donc
to
qui
a
casse la myéline
leukodystrophy,
qui
which
entoure en
is
fait la toile adhérente,
demyelinating,
et
meaning
ensuite à
it breaks
mesure que
down the
cette
myelin
myéline se
sheath.
délite, c'est
And
finalement l'axone, donc
little
le
by
fil
little,
électrique lui-même qui commence
it is
à
the
souffrir et qui est aussi
axone which
responsable des atteintes
starts
de
to
cette maladie.
get affected,
Donc,
and this
comme on
also
a dit,
leads
la
to other
particularité de cette maladie, c'est que malheureusement,
issues.
c'est 3 maladies
So
en une, avec des
it's
atteintes
3
qui, chez le
diseases
garçon et l'homme,
into
peuvent
one,
concerner les 3 parties,
and
le
men
cerveau,
can be
moelle
affected
épinière
in their
plus nerfs
brain, in their
et les
spinal
glandes,
cord, their nerves,
alors que
and
chez
in
les
their
femmes, je le
glands. And
redis,
women,
seule
as I've
la moelle
said
épinière, les nerfs
before,
peuvent être
only the
atteints.
spinal cord and the nerves
Chez
are
les individus de
affected.
sexe masculin,
So for
à peu près un
male
tiers des cas, la porte d'entrée dans la maladie,
patients,
c'est vraiment la leucodystrophie, la forme cérébrale,
usually
qui est une
it's the
maladie inflammatoire
cerebral
du
type
cerveau.
of the disease, the
Dans un peu plus
inflammatory
de la moitié des cas,
type of the
le mode
disease
d'entrée
that
dans la
starts
maladie, c'est vraiment
first.
l'AMN,
And in
l'adrénoleukodystrophy,
other
avec l'atteinte
cases,
de la moelle et des nerfs
in most
périphériques,
cases,
avec des troubles qui
the
sont plutôt en
first
dessous
issue
de la
is
ceinture,
AMN.
plutôt des troubles
So this
moteurs,
leads to
de la marche,
issues,
de
to
l'équilibre,
motor
jusqu'aux
issues,
troubles de la
issues when it comes
vessie
to
et les nerfs, donc les
gait,
douleurs.
when it
Et
comes
la
to
troisième atteinte
balance
possible,
of the
qui concerne
nerves,
aussi
and
les individus de
also
sexe masculin, c'est l'insuffisance
pain.
rénalienne et
The
parfois
third
aussi
disease that men can can have is an adrenal deficiency, isolated adrenal deficiency, which happens in around 10% of cases. So as I've said, multiple diseases are encompassed into one, cerebral ALD, AMN, men and adrenal deficiency. And you can either be symptomatic or asymptomatic and be affected in different ways. And there is one family, we cannot predict if the carrying individual will develop one or more types of the disease. So even within one single family with the same gene mutation, individuals will have different types of the disease. We cannot predict it. So the first message when we diagnose a ALD, X-linked ALD in a family, the first thing that we do is also test other boys and men for leukodystrophy and adrenal deficiency. Both are treatable, and we also test women. They may be affected too, so that we can follow up and care for these patients. But we also test them because it will be key for their future in case they want to have children. So when we diagnose a new case, it is usually linked to a familial a family mutation in 96% of cases, but in 4% of cases, it is a de novo mutation, meaning that it is a gene mutation that is not passed down to a child by an adult, and that happened in a completely accidental manner after conception. So when it comes to the cerebral ALD in children, sadly in France, we do not carry out a systematic diagnostic or screening. And so the screening happens after the onset of the first symptoms, and the disease has already progressed. And on average, 1 to 2 years go by between the onset of symptoms and the disease being screened. Usually, it's a completely healthy, normal child who around the age of 6 years old will start having issues at school, but also behavioral issues. And usually these kids will be labeled as kids with ADHD. And so the disease progresses and becomes more and more, and the body is more and more affected. So little by little, the child will stop be able to, will lose sight, will have trouble swallowing, will lose his or her his autonomy. There will also be intellectual losses, and then the disease will then become more and more inflammatory, and lead to a stronger and bigger issue. So when it comes to adrenal deficiency, this usually happens in children with melanodermia, or in children that have stomach pains and vomit on the daily, or are chronically fatigued, which is inhabitual. You also have to look for cognitive signs in a child that used to be healthy. These happen around the age of 4 to 8 years old. If a child around 4 to 8 years old begins to have issues with staying focused and thinking, you have to watch out for that. You also have to take into consideration hearing and sight and motor skills, so walking and spasticity and coordination. And if these signs are noticed, then you have to carry out blood tests and also an MRI, because it is with MRIs that you are able to see damage in the brain. And we find that damage in key regions that we know quite well, the callous body, for example, that you see on the screen. So it is what links the right part of the brain and the left part of the brain, and it's usually where we see damage in children and very young boys. There can also be the brain could also be affected in different ways, but we can see it on the MRI. And when the MRI is not done early enough, then the damage increases and becomes more invasive and progresses. And this leads to more demyelination. And so when we inject the contrast product, the product goes all the way into the brain and it shows what you see on the screen. We see inflammation, and we call that gadolinium positive. So for all little boys, there should be very comprehensive care when they are children and when they reach adulthood. So cerebral MRI should be carried out from the age of 2 years old every 6 months till the child is 12 years old, and then there should be an MRI carried out once a year until adulthood and into adulthood. So nowadays we are able to say up until 70 years old. Back then we used to say only 50 or 60, but now we're able to say 70, and maybe in the future we'll be able to say even older. So these MRIs are done to spot damage in the brain and damage gadolinium positive inflammation. The second thing that we check in boys is the adrenal glands, and we check that from birth if the diagnostic has happened pre-birth or at birth, and then this is done again at 3 months old, and then there is a blood checkup done every 3 to 6 months because you have to track an adrenal deficiency and treat this with hormonal in a hormonal way. In adults, this checkup is carried out annually, and for women, there's usually no MRI follow-up. So I'm explaining this because this disease includes pain, demyelination, inflammation, oxidative stress, and these are the targets that we are thinking about when we are considering and taking into consideration treatments. Other key message for me as a doctor, a treatment can only be effective on the cerebral ALD when it starts at the beginning, early on, when we only have very light damage in the brain, and that we are able to spot very light damage on an MRI in a child that is asymptomatic or has very little symptoms. So my colleagues have presented other symptoms such as hematopoietic stem cell transplant, but there's also ex vivo gene therapy, and I will also be talking about another type of treatment therapeutic protocol. So before getting to menorrhax, I also wanted to say that when you treat symptoms, you can also treat boys even in advanced stages. These boys have to be cared for. And this is also encompassed in care. So we have to take into consideration everything that these boys are telling us, whether it be pain or spasticity or everything that is linked to issues with breathing, bowel dysfunction, anxiety, and pain. So care for these children is always multidisciplinary care with many partners and players involved that will care for this child. So when it comes to menorrhax, my colleagues have already spoken about lariglitazone, which was involved in other preclinical studies in mouse and in murine studies. And then there was another studies that my colleague Professor Kohler talked about in adults, which started in 2018. And then in 2020, we started to use this drug in children, and specifically in boys that have cerebral ALD. So the molecule is lariglitazone, or Min-102, that we called Minrix. And as we have explained it, it is derived from another drug, which is pioglitazone, that was used to treat diabetes. So it's a very interesting type of drug because it acts directly on this tract that I was talking about in the organite, which is the peroxisome. That eliminates very long chain fatty acid. And this molecule attaches itself to a receptor that's key for treating these very long chain fatty acids. And it does so in mice, but it does so in humans as well. And we are convinced that this molecule can fight against oxidative stress and fight against inflammation as well. What's also interesting is that if you administer it orally, it can penetrate in the brain, so it can act directly in the brain. Other interesting fact, especially for children, and I have noticed this more in children than in adults, it is a molecule that is very well tolerated, meaning that all the little boys that have had this treatment administered have not noticed big side effects. We have noticed that they put on a little bit of weight because there has been an increase in appetite, but then this stabilizes. So this is a clinical therapeutic study that started in 2020 in 4 centers across the world. So France, Germany, Spain, and Argentina. France is represented by our center in Bicêtre. It's an open study, meaning that all boys are administered the drug. No one is taking a placebo. It's for boys who are from 2 to 12 years old and have early onset cerebral ALD, meaning that their LOS scores is under 0 or under 10, meaning that they do not have big brain damage. And in France, there is very little boys who are in that situation. They are either gadolinium positive or gadolinium negative, and we exclude, so we cannot include in the study boys that have another autoimmune disease, have diabetes, have heart issues, have already benefited from another treatment such as HSC transplant or bone marrow transplant, which makes sense. So I cannot talk about the results of the study because unlike my colleague that talked about the study in adult, for the children study, the results have not been published yet. So these results will probably be presented during the next ELA meeting, so next year. So we are being cautious with these results, but we see this molecule as very interesting when it comes to this disease. We hope that it will be able to halt the progress of the damage when it is just beginning. And our hope is that when we administer this treatment, in most cases possible, we can stop or prevent gene therapy, having to go through gene therapy or HSC transplant. So our main objective is to prevent or halt inflammation and demyelination. And we have 2 objectives at 24 weeks and 96 weeks. So we look at disability, and that's one of the criterion. And the second criterion is the MRI to see how the disease progresses, and the gadolinium. There's also biomarkers that are taken into consideration. I will not go into further detail about this, but they were explained in the first presentation that was given today. So this is tests with biomarkers in the blood. So when we include a little boy in this study, and by the way, this will stop on the 30th of April 2023. In France, we are currently including the last 2 patients. So we carry out a first screening visit. So we look at the heart, the blood, the bladder, and then there's another visit during which the syrup is administered orally, and then every 3 months we check up on the little boy in the hospital with a comprehensive exam, and we also carry out a brain MRI to check the brain damage and inflammation. So the 2 key points are at 24 months and at 2 weeks, whether it be for blood tests or MRI. At any moment, the boys can stop the study if we believe that the treatment is not being effective and that there should be a bone marrow transplant. So my message is that all throughout life there should be an MRI follow-up to screen for that for brain damage before it becomes inflammatory. And then if that is the case, then the patient would be a perfect candidate for Minorix. And if the patient cannot take Minorix, then the patient can go through bone marrow transplant. These are very complex cases, and we usually discuss these cases in pluridisciplinary meetings with our international colleagues that are also involved in such therapeutic protocols in their country. So I wanted to remind you that the our centers. So for all leukodystrophies and adrenoleukodystrophies, there is a center in France, in the Paris region, with the children at Kremlin-Bicêtre. The Dr. Sevin and myself are involved in this team, and we also have two research assistants, and we take part in international and national meetings to talk about the cases of the different patients that are under our care. And then the Center for the Adults is at the Pitié-Salpêtrière with the team led by Dr. Moschel, who also work with Dr. Nguyen, who is a hematologist. And Mr. Blanco is the project coordinator. Madame Scherer is the gene consultant. Madame Barbie is in charge of clinical trials, and Professor Dahl is the main hematologist. So thank you very much for your attention, and I can answer any questions that you have. Thank you very much.
Thank you very much, Elise, for this nice presentation and overview of adrenoleukodystrophy. So now we have the chance to have questions and answers.
So I will open the microphone of the first person in the list that raised her hand.
Yes.
We'll see if she can open her microphone. It is Mariana Bugarski. If you'd like to ask your question.
So Mariana.
Hello, everyone. My daughter have leukodystrophy. Sorry for my bad English. I am from Serbia. She have 17 years. Most of that of MRI and blood we do it in Belgrade, and I want to thank you for such a detailed presentation and speech.
Thank you very much, Mariana.
I just want, yes, I have question. In my country, that's a rare disease. Don't have in the protocolary for my country. Don't have the, I don't know how to say cifra number, and we don't know how to do it with carry, but of
yeah, I understand.
That's the money who which country needs for carry of my daughter.
I understand, Mariana. This is a frequent problem in many other countries as well.
Okay.
It's not always the same thing. Maybe one idea could be that there is an European initiative that people from Serbia also can join for diagnosing and discussing rare diseases. So people can find this on the internet and be part of this initiative. So this could be a first step. The other is, of course, that you need treatment centers in your countries as well. Yeah.
Yes, I think she's the. I think I don't know. I don't have a medical science documents, but I think she's the only one in our country.
Yeah. Thank you very much for this.
Yeah.
Thank you.
Are there more questions? I can see in the chat some
So we'll
questions.
have a question from Patricia O'Sullivan, if you'd like to open your microphone.
Okay.
Hello, can you hear me?
Yes, I can hear you.
Hi, I'm joining you from Ireland. I was just wondering if in the future there's a possibility that you think Lair Iglitazone will be available for women, or is it?
Oh, yes. I hope very much that this will be the case. See, Patricia, in my eyes, AMN or the symptoms in women are very similar to the symptoms in men. So there's no no real reason not to have to use the beneficial effect once it is proven. Of course, the men usually progress a bit quicker, so this is why the men are used for the clinical trials. But the same results are, of course, true for the women. But all depends on the authorities, the European authorities in our case, if they will accept that this treatment will also be available for women. I hope so. I really hope so. But I don't know yet because we have to wait for the decisions of the authorities by the end of this year, hopefully.
Well, thank you. Fingers crossed.
Yes. I cannot read all the questions in the chat because they're in French. I'm not so good in French.
So I will open the microphone for Jean-François Platarotti. If you have a question.
Okay. Jean-François?
Ah non, moi je souhaite pas poser une question. Hein.
Ah, pardon.
I didn't want to ask the question, Jean-François. That's okay.
Okay.
Alors la prochaine main levée. Attendez.
I have this is Elise. There's a question in the chat in French about the neonatal diagnosis. Why isn't it in several countries? So this French person is asking. What I can say that we aim for it and we wish for this in France and in several countries. And it is really our goal because it's the only way to make the diagnosis very early and to treat the cerebral forms when they are very little. So what is preventing us in France is mainly ethical and economical issues, but we will fight for it, and we know that it is really important, and it is one of our goals.
Yes. Thank you, Elise. I think this is extremely important question. There's initiatives in many other countries as well, England, Germany, but also other countries. And as you know, there's the pilot project in the Netherlands, which we can use results from. So this is in the light of having new treatments, of course, this is very important to detect patients at risk as early as possible. So this is very important to have this diseases included in the newborn screening, This is true for ALD, but also for MLD and maybe others. So this is a very important issue, which we have initiatives in many countries in Europe and US.
Wolfgang, I also found a question in the chat concerning the trigger of CLD, and it was asked what kind of environmental trigger could somehow trigger CLD. And of course, this environmental hypothesis came from this study that was done in monozygotic twins, where one got CLD and the other not. And and also recently, there was a study that was done in MS, and there it was found that is really closely linked to causing an MS is the EBV virus. And so it could be a hypothesis that such an environmental trigger could, for example, be a virus. Yeah. And we also did some research in this direction, and I found it interesting that what we found was that the ALD function of the protein is also involved in somehow in this antiviral response that cells have. So I feel maybe this also points in this direction, but of course, many research has to be done to really clarify this.
Yeah, this is kind of very preliminary results, Isabel.
Yeah, but for MS, it was strong data, no?
Yeah, for MS, it's strong data. That's true. This is a very broad discussion. We have some patients who have initial brain trauma, which is causing or starting afterwards with cerebral ALD. We have seen these cases, but it's not systematically investigated yet. So this
Yes.
is work, open work. Yeah.
Yes, that's I also want to say. Yeah, so it might not be the solely trigger. Yeah, there are many different maybe.
So we can open the microphone for Mariam Mawe. Mariam, if you'd like to ask your question.
Yes, good morning. I had a question. So we've been talking a lot about gene therapy, but it's no longer available in Europe. So how can we have access to that type of treatment?
Would you like to ask? To answer?
Yes, so in French, right?
I think it's a European problem. You can expand it to Europe.
Okay.
Even though you're only speaking French.
Yes. Actually, in Europe and in France and other countries, when we need something more than Minorix or a treatment by oral that are taken orally, we just try, first of all, the HSCT. So we try to find a donor. And if HSCT is doable with a sibling donor, brother or sister that is compatible for 1010, so this is perfect, and we know that we won't need the gene therapy. But in ALD, when we have to do something else than Minorix and we do not have a good donor, we might need the gene therapy. And this is being very difficult because since 2020, we don't have anymore the gene therapy in Europe. So it is a battle. Some families that need it, I have in mind one Italian family. They are asking their social security and their government to help us to pay the fees to be able to have the treatment in the USA. So this is now the way they are trying to find, because it's a very expensive treatment. And for this Italian patient, the discussion is now, can the treatment be administered in Italy, or does it have to be done in Boston or in the USA? So this is a question that I cannot answer, but mainly it's a treatment that is only being done in the USA for now.
Do we know if European families have had access to it in the US, that were able to have access to this treatment in the US ever since it's no longer accessible in
the French experience,
in France?
The only time we need it is now, and it is in process. The treatment has been accepted for the boy, and now the parents are searching for the funds to get the treatment in the USA. So the experience is now going on.
I'm not a pediatrician. Oh, Guy, you want to say something? Yep.
Yes, maybe I could add to what Elise said on this issue. So gene therapy in Skysona, I'm assuming this is what you're referring to, has never been used in Europe. The first child that could have access to it in 2021 will no longer have access to it because in 2021 the lab decided to refocus on the American and Northern American market and left the European market for economic reason and financial reasons. Of course, they didn't just do so because they wanted to. And so nowadays, families could potentially go to the US for the treatment. I don't know if that's possible, but what I'm sure of is that for a country such as France, for now, France will refuse to fund a treatment for a child to go have treatment done in the US. I don't even know if that is possible. There's many issues that come into play. The child has to be screened early on. You also have to go through a red tape. You know that this is a race against time. It's very difficult. So what you maybe do not know is that this treatment costs $3 million. So I don't know many families around me that could, in a very short term, be able to gather $3 million without having to sell their house or something else. And so the only solution, of course, would for health authorities and health ministries in Europe or Europe itself except to exceptionally fund these treatments. As ELA International, we did ask the French ministry, the French health ministry, and we have not, and the response was negative. So there are two parties involved. On the one side, you have a pharmaceutical lab, Bluebird Bio, that invested for this treatment to be able to be granted a marketing authorization in Europe and then in the US. And so we don't know the numbers exactly, but these were very hefty investments. And on the other side, you have ministries that, of course, stiffen up a little bit when they hear about how much the treatment costs. It's a couple millions per child. And of course, there is an issue when it comes to that. The main limit of gene therapy nowadays is its cost, its commercial cost. Of course, we are pushing to denounce this situation for patients, and we will continue to do so because it is an intolerable situation. It is not acceptable that children that need this treatment do not have access to it because these children cannot have a transplant done. And so patients are angry. They're legitimately so. And I believe that we should mobilize to make sure that things change. So what I can say for now is that we will have to be patient because even if the American lab were to decide to come back to Europe, this would take time because the authorization that they were granted in 2021 is no longer is no longer accepted, and so they it would take a lot of time for them to come back on the European market. So we are not giving up hope, and we will continue to fight on. I have seen the different messages by parents that have said that we should exert pressure on the authorities, on deputies, on ministers, and we know then that it's not as easy as that. And once again, we should ask for things to change as soon as possible.
Thank you. There is a question maybe from Valentina Fasano. Valentina, if you'd like to open your microphone and ask your question.
Grazie mille. Buonasera, io volevo sapere se
Hello, good evening. I would like to know if you are planning to start new trials for leriglitazone, and if it's going to be possible to involve the different associations in the research activities to be carried out in connection with these trials.
Also, was Leriglitazon betrifft, ist es, concerning Leriglitazone, steht das Medikament im Moment.
Well, concerning this,
there is the
I'm sorry.
possibility of using Leriglitazone in adult cerebral patients on a compassionate use basis. And we, of course, hope that that it will be approved very soon for all kinds of ALD patients in Europe. Maybe in US it's a bit more difficult. So this is why the US there should be an international, or there should be a controlled trial in addition to the data that we have from Europe to get more information about adult cerebral variants of the disease. But I think we have to wait for another couple of months to get the results from the authorities if this treatment is available for all kinds of adrenoleukodystrophy variants in Europe. And I'm very optimistic about that.
Thank you.
Thank you, Dr. Keller. That answers your question. We can have, I don't see any more hands. If you'd like to ask a question, please raise your hand, and we will give you the opportunity to ask.
I'd like to make a comment on the gene therapy in children. I think it is very important what Elise was saying, that stem cell therapy at a comparable stage where the gene therapy is performed is at least as successful as the gene therapy. So this is a very good alternative, which is available in all countries, and in which we have long-term results that are extremely good, saying that we are looking at the same kind of patients which are used in the gene therapy studies. So in the gene therapy studies, there's no experience in more advanced patients that we are still treating the stem cell therapy. So, and in addition, there are new problems, long-term problems coming up with the gene therapy in childhood, secondary diseases coming up that are significant. So yes, it is absolutely true. If a treatment is available, is approved, is proven helpful in a certain situation, it should be available for everybody and not only for those who can afford the $3 million. This is completely unacceptable. But we should not, at that point, not overemphasize the effects of the gene therapy versus the good effects that we have in stem cell therapy. A more important problem is to have a newborn screening and detect children as early as possible, and to have the stem cell therapy as early as possible. This would really be helpful and would save many lives. So this I want to say with this.
Thank you, Dr. There is a question from Shahana Abbasovas. If you'd like to activate your microphone, and you can ask your question.
Hello.
Hi, Shahana.
Hi. I am from Baku, Azerbaijan. My second child, boy, he diagnosed Pelizaeus-Merzbacher disease. I don't know. In our country, we have this is rare disease. Yes, I don't know any treatment, but every day we do physiotherapy.
Yeah, Shahana, this is an important question. Thank you for that question. But of course, we are not today. We are not talking about Pelizaeus-Merzbacher disease. I think this is on the table tomorrow. I think. Let me see.
Tomorrow.
Yes, tomorrow.
Okay.
No, in the afternoon. No, today in the afternoon. So starting at 4:40, you will hear more about Pelizaeus-Merzbacher disease.
Oh, thank you.
Stay with the group.
Okay, thank you.
Thank you very much. I guess this was the last question. We're perfectly on time for the break. So thank you very much, Dr. Carler, and all the presentation today.
And I also want to thank all speakers, and of course I want to thank Guy and Elise and all the team from ELA for have this wonderful meeting in place. And I think it was very helpful for many of the listeners. And thank you again very much.
Thank you very much. So we'll have a short 15-minute break, and we'll see everyone after the break. Thank you. Please go ahead, Nicole. Thank you.
Thank you, Elise. Bonjour, bienvenue, good afternoon. Welcome to the second session of the first day of the ELA family meeting. And we have an exciting program about genetic and undetermined leukodystrophies and hypomyelinating leukodystrophies. So the first speaker is Laura Adang, a child neurologist from the Children's Hospital of Philadelphia, CHOP in the United States. And the CHOP has a very active leukodystrophy unit where a lot of clinical and basic research on leukodystrophies is being done. So Laura, thank you for being here, and please go ahead with your talk on undiagnosed leukodystrophies.
Thank you so much for inviting me, Nicole, and to the organizers. It is my pleasure to join you here today. And my pleasure to talk about a topic which is really an area of interest of mine, but really the work that I'm going to be presenting is largely based on the work of other researchers, many of whom are based in Europe. So today I'm going to talk about the diagnosis and management of undiagnosed leukodystrophies. I am a pediatric neurologist, and so I'm going to largely focus on pediatric disorders, or predominantly pediatric disorders, and how they are presenting in adults. I do have some disclosures. I work with several pharmaceutical companies on drug development and in natural history studies for rare diseases. I have NIH funding and several sources of funding from amazing parent advocacy groups. Today, we're going to talk about the challenges with bias in diagnosis and how that changes what we understand about what a leukodystrophy is. We're going to talk about unexpected leukodystrophies. So when leukodystrophies are presenting outside their typical age range or phenotype, which is the way they present in people. We're also going to talk about the general care for the leukodystrophies. So in the past decades, we've really refined our ability to recognize leukodystrophies from an imaging picture or an MRI in particular. And there are some really classic MRI features that allow us to look at a single picture and have a good degree of certainty about which leukodystrophy it's going to be. There are some leukodystrophies that really are abundantly clear. But one challenge is that what we know about leukodystrophies and how they look on imaging has a lot more to do with when we've captured these individuals. And almost always, with rare exception with siblings or with newborn screening, we're capturing what the images look like many months to years into the disease course. And so it's actually, we're less certain about what things look like at the very beginning. And as we start moving towards pre-symptomatic testing and newborn screening, I think we'll have a challenge of how to recognize leukodystrophies and the emergence of myelination defects in the context of children are developing myelin. And around 2 years of age, the myelin looks fairly mature. But honestly, we don't finish myelination until 25 years of age. And so we're looking for subtle differences in how myelination is occurring in many of the leukodystrophies in the context of the myelin is changing itself. And it can be very challenging to pull out these very subtle signs. We've started to move less from targeted testing, where we think a child has something like metachromatic leukodystrophy, and so we only send the genetic testing for MLD. We've moved much more into broad-based testing, things like large panels that test for hundreds of genes at the same time, or exome, which looks at the coding regions of our entire genetic information, to even in some cases using genome, where we look at the non-coding regions as well. When we look at the distribution of how common leukodystrophies are by more broad-based testing, which is less biased because we say, we're not certain. Let's see what we can find in a child with non-specific MRI features. And we see distributions that are possibly different than we expected. You'll see on this chart some things like ARSA, which is associated with metachromatic leukodystrophy, and ABCD1, which is associated with adrenal leukodystrophy, are underrepresented. That's probably in large part with the fact that we oftentimes will send biochemical testing for these diseases and therefore not rely on things like genetic testing. But other disorders like the AGS or Cardi-Gutierrez associated genes or TUB4A leukodystrophy are overrepresented or represented more than we expected when we start sending more broad-based testing. And part of this is due to something called ascertainment bias. That means if we think a disease looks one way, we're only going to send testing for that gene in a clinical situation where it looks that way. And this is an example of a Cardi-Gutierrez syndrome in our natural history study of 200 patients. And I scored each one of the motor function or the language function, as shown in red and blue, for each one of these individuals. And if you look in the literature for AGS, the vast majority of the time, children are being described as having an ultra-severe early onset form of disease that looks like a congenital infection. But in reality, that's not actually what is representing the majority of cases with AGS. And while those cases do exist, when you look here, there are just as many children that have independent mobility as compared to those that are non-mobile. And that discrepancy is even more pronounced when you look at language function. And we see that in our clinic. Children may have severe motoric disability or difficulty moving, but they're able to speak in full sentences. This doesn't even capture their ability to use things like language boards and form complex sentences using augmentative communication. And so if you thought of AGS as being an early onset, universally devastating disorder, you wouldn't go looking for AGS when you have a child with mild spasticity that began at, say, 9 months of age. You wouldn't look for AGS outside of what your preconceived notions or your anchoring bias, or sometimes called ascertainment bias, is. And you would miss children that are able to take their wheelchair, fit it to become a dune buggy, and go drive their wheelchair over the beach and speak in sentences using augmentative communication, because that's not who you were expecting. And so my plea is for us to really think broadly and understand we likely know the common phenotypes of diseases, but we oftentimes don't know the full spectrum until we start testing children pre-symptomatically. Another challenge is that we're fairly slow at diagnosing leukodystrophies. And we call this the diagnostic gap, the time from when the child first began to have challenges to when they actually reached a diagnosis. And we're getting faster. And in some cases, we're moving down towards the months. But if you look across a large cohort, there are some people that have waited years, decades to reach their diagnosis. And that may be because of access to diagnostic testing. That might be because they had an atypical presentation, and therefore that anchoring bias limited our ability to kind of think outside of the box for a diagnosis. This is an example for beta propeller protein-associated neurodegeneration, which is an iron brain accumulation syndrome that we study at the Children's Hospital of Philadelphia. And we can see that there's a huge range of people that have waited months to get a diagnosis to those that have waited years. And this delay in diagnosis is both emotionally disturbing for families. It keeps us from getting therapies into children and helping. It thwarts our ability to develop clinical trials, but it also biases about what we think a disease is. If we're always missing the first months to years of a disorder, it's going to be very challenging as we start pre-symptomatically testing, recognizing those early disease features. And prospective natural history studies, which is where people tend to come in person and at very fixed intervals similar to a clinical trial, you measure how a disease is changing. You get a great cross-sectional look at how you can measure different functions. But the challenge is that is by necessity only happening after the disease has begun. Because how else would you know to enroll a child into a natural history study? And so a lot of our prospective natural history studies are biased towards understanding the middle and later phases of disease, but are really missing that time period where we want to be measuring change. I'm going to give a little bit more of an example on our work on BPAN, which is beta propeller protein-associated neurodegeneration. This is described in the literature primarily of an adult onset disease that causes Parkinsonism or movement disorders in adult women. So in the teenagers and young 20s, women start to develop what looks like Parkinson's. But we were finding in our leukodystrophy clinic, we were finding quite a few young girls with delayed myelination, what looked like autism, who have relatively intact motor or movement skills, but really had difficulty with language development. And as we started sending broad-based testing like genome and exome in this population, we are finding more and more of them were actually diagnosed with something called BPAN. And BPAN is, again, an iron accumulation syndrome. But depending on the age group you look at, children can look dramatically different. And this is one of the little girls that helped us launch our dedicated BPAN clinic. And when you look at the youngest children, they have developmental delay. They look like they have autism. It's primarily a disease of girls. It's thought to be largely embryonic lethal in little boys because it's X-linked dominant. But the youngest girls had abnormal myelination. They were appropriately triaged towards our leukodystrophy clinic. And very, very few of them had iron accumulation, which does not begin until roughly a decade after the myelination defect. So the myelination actually improves. And then you begin to develop iron deposition, which becomes challenging. When children are presenting to a leukodystrophy clinic, we are seeing the myelination defect. And when they're presenting later in life, they go to movement disorder specialist. So even within neurology, we have our blinders on and we're not looking for these disorders that maybe are presenting differently in different age ranges. It's important for us to really look across the hospital because our children with leukodystrophies are likely undiagnosed and sitting in different clinics. Within the ophthalmology or eye doctor clinic, there are children with metachromatic leukodystrophy that are presenting with strabismus and esotropia. In the ENT or otolaryngology clinic, there are children with MPS disorders and multiple sulfatase deficiency presenting with recurrent ear infections. In the dentistry clinic, there are children with abnormal dentition with 4-H disorder. In the dermatology clinic, we've gotten many a referral from dermatologists that saw children with Aicardi-Gutierrez syndrome with chilblains and referred them into our clinic to investigate whether they actually had an underlying neurodegenerative process. Several of the leukodystrophies can present with ichthyosis, which is a dry scaling of the skin, including Sjogren-Larsen syndrome and MSD. And there are some disorders like CTX or cerebroxanthomatosis that can present actually with systemic disabilities like chronic diarrhea decades before the neurologic degeneration. And so many of the children with CTX actually are in GI clinics and no one is looking for the role of a neurologic degeneration gene because their neurologic development is normal at that time. There are many case reports of children with metachromatic leukodystrophy presenting with gallbladder disease before they present with neurologic issues. And in the endocrine clinic, there are children with short stature and 4-H disorder and adrenal insufficiency with ALD. And so again, depending on the lens in which we view these disorders, we have a very myopic view of only thinking about the neurologic sequelae. But in many of these disorders, the systemic sequelae or the systemic complications of their leukodystrophy can actually come first. And so we should be looking in these clinics to help diagnose and support families earlier. I think it's important to know that it's not just other doctors that are missing the leukodystrophies. It can be the neurologists too. And I'm going to present a series of 3 papers, which are older papers, but really are lovely examples of what happens when you look in neurology specialty clinics for patients that aren't quite fitting the mold. In this first paper, they looked in a spasticity or a leg stiffness clinic, and they took 76 patients and divided them into those that had just stiffness of the leg versus those that had other problems. Balance issues, which is ataxia, a peripheral neuropathy, which is an irritation or breakdown of the nerves that connect from the spinal cord to the muscles. Dystonia, which is that twisting abnormal tone. Epilepsy, which is seizures, and cognitive dysfunction and psychiatric issues. And they also looked at what the MRIs showed, and they found white matter lesions in 19 of the patients and cerebellar, which is the area in the back of your brain that controls balance, lesions in 10. And they found what I think is a very high rate of abnormalities. Among their spasticity clinic, 11% had cryptogenic causes, right? So, or had causes that when they sent the neurobiochemical testing, they found an answer. Not surprisingly, 4 of the patients had AMN or adrenal myeloneuropathy. 1 patient had MLD, 2 had Krabbe, and 1 was noted to have vanishing white matter disorder. I think it's important to note that these patients weren't the ones that just had pure spasticity. They oftentimes had concentration issues, orientation, poor performance on cognitive testing like the mini mental status exam. And so it really was a question of spasticity plus something else. And to think outside the box, one of the cases that they found was a patient with Krabbe disease, which is a severe disease we think of as primarily affecting young children and infants. But here's a 72-year-old with Krabbe. At 47, they were incidentally found to have an abnormal exam finding. And they had a full and appropriate workup, which was normal. A decade later, they were still having difficulty walking, and it was worsening slowly. And so they had another full workup, which was appropriate and was again negative. And it wasn't until a full decade later, so 20 years after they sent for the original testing, that they were noted to actually have some abnormalities. They had some MRI abnormalities and some abnormalities on the peripheral nerves. And this led for them to have the specific testing sent. And so while Krabbe is, yes, by and large a disease of young children, it doesn't mean it only affects young children. And when we start to look in our adult clinics, I anticipate we will be surprised and potentially horrified at the number of patients that have leukodystrophies that really have not been appropriately diagnosed. They did a similar process in their ataxia or their balance clinic. In this case, they took 105 patients with ataxia from different families, and they did basic metabolic testing, looking to see if there was any underlying cause. And there was. They found Tay-Sachs, an MLD, Niemann-Pick C, an LBSL, and CTX, right? Many disorders were found in their screen of people that were in a great subspecialty clinic for ataxia care. And similar to the previous example, it really came down to the fact that it was ataxia plus something else. And the more pluses you had, the higher the probability that there was a leukodystrophy underlying. So ataxia plus cognitive impairment was 23%, so a quarter. Ataxia and psychiatric illness, it was roughly the same. But if you had ataxia plus thinking difficulties plus psychiatric comorbidities, your risk of having an underlying leukodystrophy was 50%. In ataxia alone, they didn't find a single case. And so this guides us as physicians about when we should be thinking that something else is going on. And in a final example, this was a similar approach, but really looking from an MRI lens. So they took 154 adults who had abnormal white matter changes, and they sorted the MRIs into vascular, cavitary, which means kind of a hole, and neither. And then they looked to see by metabolic testing and targeted genetic testing, if indicated, what the rates were. And they actually found an incredibly high rate of diagnosis. For vascular MRIs, 75% of these undiagnosed cases were diagnosed. For cavitary MRIs, the vast majority of them were vanishing white matter disease. And for the ones that fell into no clear category, there were 23 cases of enzyme deficiencies and other genetic white matter diagnoses. So in these undiagnosed cases, over 50% of them were diagnosed ultimately with a genetic metabolic disorder. They found, not unsurprisingly, adrenoleukodystrophy, CTX, Krabbe, MLD, among other neurometabolic testing. And in closing, I'm going to talk about, yes, it's important for a diagnosis. I acknowledge that that's a really incredibly powerful point in the journey. It helps to guide future clinical care. It guides eligibility for any targeted treatments and clinical trials. But in the end, many of the care can be shared. And that when we compare children across the leukodystrophies and what their needs are in clinic, there are many, many more commonalities than there are differences. I would say that all patients affected by leukodystrophy need to be seeing a neurologist, a brain doctor. They can monitor for seizures. They can maximize mobility, communication skills. And at least in our clinic, we function as the captain of the ship, making sure that children see all the specialists that they need and get the care to keep them healthy as long as we can. We also monitor for vision health. Many children with leukodystrophies have difficulty processing their visual information. We call this cortical visual impairment. And we also have things like vision therapy that can help to maximize how children can communicate with their eyes and see with their eyes. by using things like high contrast images rather than low resolution gray-white images. I think that respiratory health is actually one of the most important aspects of leukodystrophy care. It is an essential part of preventative care. And I make many of my families or ask them to go and see a pulmonologist or a respiratory doctor to help come up with a preventative care in case a child does get a respiratory infection. How can we keep that child out of the hospital and keep their lungs healthy? Things that would put a child at risk for a respiratory infection would be difficulty with swallowing and difficulty with neck control. These make children at risk for something called an aspiration pneumonia, which can lead to hospitalizations, and is actually one of the #1 causes of hospitalizations in children with leukodystrophies. The other thing I talk more about in my leukodystrophy clinic than I ever thought I would be gastrointestinal health and neurologic health. Constipation, as common as it is actually a major cause of discomfort in children with leukodystrophies. Constipation can lead to bladder infections, and bladder infections can lead to hospitalizations. And so we tend to treat constipation aggressively and preventatively. You don't want constipation, you want to keep it from happening. We also monitor for urinary retention. Many children who have stiff arms and legs from spasticity have stiff bladder muscles and have difficulty voiding or emptying their bladder fully. This puts them at risk for urinary tract infections. And last but definitely not least, we help to manage musculoskeletal health. Many of our children have difficulty with mobility, which compromises their bone strength. They're at risk for osteoporosis and bone fractures. And so many of our children, we monitor vitamin D levels, and we maximize the amount of time children are upright. In those that are unable to walk on their own or with a walker, we like things like standers. Even just having that pressure or weight on your bones a little bit each day keeps them healthier than children that are lying down all day. Another major challenge that we treat aggressively is muscle health, and so tone. That's the tension your muscles are when they are at rest. We use physical therapy, occupational therapy, splinting, but also tone management medications to make sure children are comfortable and really able to move maximally. So in conclusion, leukodystrophies are a spectrum. And the more we look, the more we find. And the more we look, the broader the spectrum is. We have anchoring bias that makes us all think of leukodystrophies in one certain way. But as we meet more families that are diagnosed through other routes, we're finding that the spectrum is really changing how we're thinking about leukodystrophies, both by age at onset, how it's presenting, and ultimately what the course is. It's essential as we're moving towards newborn screening and for targeted therapies that we really understand the full impact of a leukodystrophy across an entire lifespan, not just with a very narrow view of what the disease is. I am thrilled to be part of this community because there are better diagnostic and treatment options very, very near on the horizon. And we will be ready as a community, but we need to realize that as we move towards things like newborn screening, we need to adapt what our understanding and knowledge is for each one of these leukodystrophies to help support families as best as we can. So with that, I want to thank you for your time and attention.
Thank you so much, Laura, for your extensive presentation on also non-neurological features of certain leukodystrophies. Elise, will the questions be at the end of the entire session or after each talk?
Yes, we'll take the question at the end.
Okay, thank you so much. And who's next? I think I'm next, the next speaker, or is it Fifi?
Yes, that'll be you.
Okay, so I will share my screen. Good afternoon again. I will talk about news in hypomyelinating leukodystrophies, my disclosures. So my name is Nicole Wolf. I'm a child neurologist at the Amsterdam Leukodystrophy Center in Amsterdam, which was founded in 2000 by Mario van der Knaap, who has identified many new previously undiagnosed leukodystrophies. We are a huge team. That's only a part of it. And you see here the senior investigators of the center. You see 3 doctors, Mario van der Knaap, Mark Engelen, and myself, a neuropathologist, an electrophysiologist, a biologist experienced in gene therapy, a molecular biologist, and another biologist. And we all work on different aspects on leukodystrophies, DNA diagnostics to make the diagnosis, look at protein function, MRI diagnostics and research, body fluid biomarkers, clinical outcome measures, which are becoming more and more important as trials are starting. We also have started with clinical trials, which was a very new experience for us clinicians, I have to say. We also cooperate with neurosurgery intravalidation for advanced symptomatic treatments of especially spasticity. And we have disease models, mouse models, tissue of patients donated to our lab, which is a very important aspect of our work. Just to recap, myelination and hypomyelination. Myelination is a very important process in the brain, and Dr. Adang already mentioned that in real life, if you look at the very fine tuning of myelination, it is only completed around the age of 20 or 25 years. For child neurologists looking at developing children, we think it's more or less completed. What you can see on the MRI around the age of 2 or 2.5 years. And this myelin is the insulation material of the nerve fibers, and myelination is the process of making myelin and wrapping those nerve fibers. Hypomyelination means a myelin deficit. And myelin is the most abundant part of the brain white matter, but you always have to keep in mind that the brain white matter is not only myelin, it's also the nerve fibers or axons, it's small blood vessels, it's other cells, immune cells or supporting cells of the brain, which are all present in the white matter. We need myelin for fast conduction of information or saltatory impulse conduction, but also for the protection and the nourishment of the axons, the nerve fibers. And myelin is also present in the peripheral nerves in our body, going to the fingers and the toes. But this myelin is a little bit different from the myelin in the brain. So not all disorders affecting brain myelin affect the myelin in the peripheral nerves and vice versa. So the normal myelination can be followed beautifully on the MRI. This is the MRI of a neonate, and that's the MRI of a 2.5-year-old child. And you see the difference of the signal of the white matter, which is almost white here and very dark gray here in the myelinated brain. And the oligodendrocytes, which are the myelinating cells and put those wrappings around the axons, are actually really not alone and need all the other cell types in the brain to do their job. And also a lot of cofactors coming from the blood, like hormones, iron, glucose, and so on. So it's a very complicated and very finely regulated process to guarantee that all those nerve fibers are myelinated at the right time. I already mentioned that disorders of myelination where you have a significant permanent deficit in myelin deposited are called hypomyelinating leukodystrophies or hypomyelination. And you can diagnose these disorders as all the other leukodystrophies too through the MRI, which looks here very much like the MRI of a neonate with this very high, almost white signal of the brain white matter. Hypomyelinating leukodystrophies are very heterogeneous disorders. We know now really many cases. I would say we are at about 30 genes causing hypomyelinating leukodystrophies. And many of those disorders are extremely rare, and only a handful of patients are known so far worldwide. The most frequent hypomyelinating disorder is Pelizaeus-Merzbacher disease, closely followed by 4H leukodystrophy. So these are really the top two disorders. And I think the third most frequent one is HABC, or hypomyelination with atrophy of basal ganglia and the cerebellum. We don't have so many undiagnosed patients with hypomyelination any longer. Unfortunately, still a few patients of mine don't have a genetic diagnosis, but most of the adults and children we see do have a genetic diagnosis. As Dr. Adang already mentioned, there are a lot of symptoms and signs and involvement of other organs beyond the brain, also in hypomyelinating leukodystrophies. And I would like to name some of them because it's important for follow-up of our patients, because you can anticipate certain complications. So frequently we see tooth problems like hypodontia, hormonal problems, cataract, which is a problem of the lens, neuropathy, short stature, abnormal broad joints, severe obstipation due to Hirschsprung disease, which is a bowel disorder. We also see severe bladder abnormalities, finger syndactyly, and so on. So let's start with the leukodystrophy, which isn't mentioned so often at the ELA meetings, which is called oculodentodigital dysplasia, or ODDD. It's an autosomal dominant disorder, and the typical abnormality which helps diagnosing this disease is this syndactyly, a joining of the fourth and the fifth finger, and sometimes also toes, which is not present in all patients. Patients with ODDD may have often a very mild neurological involvement. It's so mild that many children with this syndactyly are not tested for leukodystrophy. And neurological abnormalities like a mild ataxia and a mild slowly progressive spasticity can start only in adulthood. And the last patient I saw was diagnosed after the age of 55 years old. Sometimes young children already have mild balance problems and mildly delayed development. What is really frequent in ODDD and is a very disruptive problem for patients is a severe overactive bladder and also a small bladder volume, leading to problems with incontinence. And that's something which should be asked about and also should be treated in those patients. Many patients also have tooth problems with very severe tooth decay. And some of them tell me that as children, they got always told off by the dentist because the dentist thought they would never brush their teeth, which wasn't the case. That's a problem of ODD too. Eye problems can include glaucoma, which also has to be checked for regularly. So as Dr. Adang also told you, it's important to keep all these complications in mind for a good clinical care of our patients. And these patients are often adults and should also be seen in specialized clinics. 4H leukodystrophy is nowadays much better known than it was 10 years ago. The 4H stand for hypomyelination, hypodontia, hypogonadotropic hypogonadism, so endocrine problems, lack of teeth, and lack of myelin. What we also see in most children, at least with the variants in POLA3B, is myopia, which can be severe and can lead to complications like retinal detachment, usually in older patients. About half of the patients with 4H have a small stature, sometimes due to growth hormone deficiency, and rarely we see hypothyroidism. But some of these complications are easy to treat. For example, the hypothyroidism, so regular checkups are important. Last year, together with colleagues from several countries, we described a new hypomyelinating leukodystrophy with inflammatory bowel disease and immune problems. Most of the children had additional involvement of either the bowels with the early onset severe diarrhea and bowel inflammation, like you see in colitis ulcerosa or Crohn's disease, or they had immune deficiency, and one patient developed very early a lymphoma, which is unusual in such young children. There was also a group of patients from the Amish population in the US who developed, who were born with the multiple intestinal atresia, so multiple blockages in the intestines, which meant that they died from that, so that it was too early to see whether those patients also would have developed hypomyelination. This leukodystrophy is caused by recessive variants in this gene PI4KA, and it interacts actually with protein we know from another hypomyelinating disease, HCC, or hypomyelination with congenital cataract. And interestingly, those patients don't have the inflammation, the bowel inflammation or the immune deficiency. Some words about new findings in MRI for Pelizaeus-Merzbacher disease. Inga Harting, a neuroradiologist from Heidelberg, together with our group, developed a very detailed score for Pelizaeus-Merzbacher disease MRIs to score myelination and tested it with the different neuroradiologists. It's a reliable and reproducible scores. Patients with classic Pelizaeus-Merzbacher disease may improve with their myelination scores. You see those green lines until about the age of 10 years. And there's also the distinction between classic and more severe PMD forms possible at already a very young age by MRI. I think this is important information for the upcoming treatment trials, because you have, even without treatment, already some improvement in myelination. And also when you try to select the patients for different treatment trial arms, you can already see at a young age, for example, with an unknown genetic variant, what form of PMD you will need to consider in a given patient. Regarding treatments, the treatment with the deferriprone and iron chelator is about to start. We've included the first patient in Amsterdam, and it's done after a group in the US and the UK found that iron chelators can improve PMD myelinating cell functions and also improve PMD mouse survival. This is a treatment with some side effects, so we will see how it goes in these relatively young children with the PMD. We will treat the children for 12 months, look at the motor function, and of course also at the brain MRI, and there at myelination. We will score that with the Harting score. We will also try to find new biomarkers, and participation means MRI under anesthesia at the start of the study and after 12 months, including a blood and CSF study, and weekly capillary blood tests, which is quite a thing, but it's necessary to check for side effects. We will include patients until the age of 8 years from the Netherlands or very close by because of the frequent blood tests, and include the severe forms, conatal and transitional forms, because it's certainly in milder patients very difficult to separate this from possible treatment effects. Other studies in PMD, for patients with a PLP duplication until the age of 8 years, there's a natural history study going on, and we've included the first patients, and there are 4 centers in Europe, 1 in Australia, including patients for that study. And planned is a study with antisense oligonucleotides with regular injections into the cerebrospinal fluid. This treatment was also effective in a PMD mouse model, and that study is primarily aimed at PMD patients with PLP1 duplication too. So there is something going on, and that's very rewarding that we start to have at least ideas how to treat our patients, and that we can test different treatments. So what we've learned in the last years is that hypomyelination are really many different disorders. Genetic causes and disease mechanisms are variable. Severity is very variable. Other organs are commonly involved, and this needs to be monitored in certain diseases. Information on natural history is still extremely important, also for upcoming treatment trials, which are starting. Thank you so much for your attention. Okay. So the next speaker is Dr. Fifi Heine, Associate Professor from the Amsterdam University Medical Center, and previously also part of the Amsterdam Leukodystrophy Center. She moved on to new research adventures, but she is still busy with a beautiful project on cortical interneuron involvement in 4H leukodystrophy. So Fifi, we are very glad that you are here and will share your results on that project. Thank you.
Thank you, Nicole. You can hear me well?
Yes,
Great.
thank you.
Then I'll start sharing my screen. And I hope you can also see my screen now as well. So thank you, Dr. Wolf, for the nice introduction. I'm glad to be here and give you some insights on the studies that we have ongoing in the lab. I have a biomedical background. I'm not a physician. My expertise is on stem cell biology. So that's also what you see back in my talk. So we use stem cell model systems to get better insights into different disease mechanisms. And here we focus on 4H leukodystrophy. Dr. Wolf already nicely introduced 4H leukodystrophies. The classical characteristics are hypomyelination, hypogonadotropic hypogonadism, and hypodontia. But as indicated, there are more characteristics, and the clinical spectrum can be quite broad. One of the other clear features that can be seen is cerebellar atrophy, as indicated here on the MRI image with the blue arrow. And also in recent years, there are more and more cases identified that maybe not show a very clear hypomyelination defects in the white matter, but show more a neuronal phenotype, more defects in the gray matter. So it's asking for also more insights of how these known disease mutations are leading to these different phenotypes. Also, as was said, for age is caused by mutations in the genes that are involved in the function of RNase polymerase III, as indicated here, the different genes and the structures they can form. And RNase polymerase III is involved in transcription, so the creation of RNA molecules from DNA, and specifically it's involved in creating what we call small non-coding RNAs, and they have different functions such as regulating transcription, RNA processing, ribosomal assembly, and also in the end regulating protein levels. And these are mechanisms that are actually important in all the different cell types of our body. However, it is becoming clear that, or we know that these genetic changes are more affecting certain cell types in our body. And here, with my neuroscience background, we focus more on the brain phenotypes. So for scientists, it's quite often important to have good model systems, disease model systems, to really look into how different genetic changes are affecting different cell types, brain cell types, how it's influencing different biochemical pathways. Those could be mouse models, but what we focus on are the patient stem cell models. And specifically, we use induced pluripotent stem cell technology. It's maybe already, it's quite a new technology, but I think it's quite getting known in the field. So we now have the opportunity to take blood or skin fibroblasts from a patient or any individual, and in a cell culture dish, we can what we call reprogram these adult cells to very early stem cells that have still embryonic stem cell-like properties, which means they can differentiate and still in all the different cell types of our body, such as different brain cells that we focus on. And these cell types are more and more used in research, so also in the leukodystrophy field, to create patient stem cells and to study in a cell culture dish why these cells develop differently in certain neural cell lineages. And they're also more and more starting to be used to set up screening platforms to see whether we could identify new drug targets or maybe even new compounds that can normalize these phenotypes that these patient cells show in a cell culture dish. So it's a very upcoming field, and I will focus on this IPC technology. Here again, you see we used quite a lot of skin fibroblasts, but also blood samples, the reprogramming, and then we have the patient IPCs in a cell culture dish. And from there, we can create different neural cell types, and we also have over the years developed different protocols. And in the brain, we have different types of glial cells, so we can create astrocytes and even different type of astrocytes, neurons, different type of neurons, microglia cells nowadays, oligodendrocytes. But also the field is shifting from the more monocultures, just generating one cell type, also creating different types of cell types in one cell culture dish, that you have co-cultures, but also nowadays people more and more start to generate brain organoid structures that are more representing forebrain structures or the cerebellar or the midbrain. So we never have a full three-dimensional brain organoid or brain in a cell culture dish, but these three-dimensional structures are only representing certain regions of the brain. But these are typical that you have different neural cell types. And we also feel that these organoid structures could get closer to the in vivo situation. So for 4H syndrome research, we started to generate cerebellar organoid structures. So cerebellar atrophy is one of the characteristics that is seen at least in a subset of the patients. So we created from control iPSC lines and patient 4H patient lines, we created these three-dimensional organoid structures that are typical for the cerebellum. So we have in the beginning a three-dimensional structure that you actually by eye even can see, but then we, what we say, fix the organoid structure and create very thin slices. And then under the microscope, we can add different antibodies that are specific for specific neural cell types. So we can identify and study the different cellular structures and layers and to see whether there are differences between the control and the patient cultures. There were no obvious differences when we looked at the morphology of the structures. So we followed up by doing a RNA profiling. So we captured the complete pool of transcripts of these organoid structures. And we studied to what extent the transcripts were different between the controls and the patients. Well, we found several differences. And one of the differences we really wanted to follow up, that was that we could see that ARCS, which is indicated here in the graph, is decreased in expression in the 4H cultures. And why ARCS? Because this gene was already known for a while to be involved in the development of the brain. And there were also already patients known that if you have genetic changes in the ARCS genes, that could lead to cognitive dysfunctions and epilepsy. So we felt maybe also ARCS could be involved in 4H leukodystrophy. As I said, we knew already that ARCS was involved in development of cortical interneurons, so the interneurons that are more present in the forebrain structures. And what we created here were cerebellar organoid structures. So to answer, is ARCS also involved in cortical dysfunction in the 4H brain, we went on to create other types of cultures, mixed neuronal cultures that are typical for the cortex. And also at the early developmental stage, when we call the cells not mature yet, but still in a progenitor stage, we already looked at whether, still another image here, just I want to emphasize that these cortical cultures have different types of neurons present, also the different types of neurons that we have in the cortex. And these are very long names, so like the glutamatergic excitatory pyramidal neurons. Well, those are the neurons that are giving stimulating activity to other neurons. But we also have different types of what we say GABAergic inhibitory interneurons, and that actually is a broad spectrum of different types of cells that are able to give more inhibitory signals on different levels. And all these different neurons are in a tight network, and they regulating the activity in this network, which in this over a long distance, you can get a complex network of complex activity, and the different cells are contributing. And that is what is needed to perform, or for us to perform, the different complex functions. So in the cell culture dish, we have different types of neurons. At an early stage, when the neurons are not really mature yet, we already want to see, are these cells also in culture expressing ARCS? And then the answer was yes. And what we also saw is that in the 4H neuron cultures, we saw a decreased expression of ARCS, which was encouraging that we actually work with the right model systems, the right neurons to study this further. what I depicted here in the bottom, so when neurons are becoming more mature, then they can have different identity that I just indicated, but very typical for neurons is that they make connections. We call those synapses, and we can also visualize those synapses in the cell culture dish. They give a spotted spectrum in the cell culture dish. Those are the connections, and we have different types of connections between neurons, the ones that are stimulating, but also the ones that are inhibiting, and in that way regulating or fine-tuning the signal that is going from one cell to the other. So here I'm showing you some example of the control cultures and the 4H cultures, and we added different antibodies to visualize different antigens in the cell culture dish. So the map2 is more showing the morphology of the cells, but what I said, those connections, those synapses can be visualized by synaptophysin 1, that is showing all the different connections in the cell culture, and VGET is specifically identifying and showing those connections that have more in a inhibitory function. And when we quantified these numbers, we saw that the total number of synapses in the controls versus the 4H is similar. But if we look at the inhibitory synapses, the inhibitory connections, then we actually saw a decreased in the 4H. So in the 4H neuron cultures, there are less inhibitory synapses, those GABAergic positive connections. And we now wondered, okay, are these changes in synapses and the composition, is that also leading to a changed neuronal network activity? And after that, we also studied whether we could identify what interneuron subtype, because there's a whole spectrum, is there a specific interneuron that is more affected than the other? So, so we again plated the control and the 4H neurons. So we did this morphological analysis, that was the synapse analysis. But in parallel or following, we also plated the neurons in a special cell culture plate, what we call a multi-electrode array. And this is this special cell culture plate. And instead of a regular bottom, just a plastic bottom, on the bottom we also have electrodes that are able to measure the activity that the neurons are giving out. And we can measure this activity over time and in the network. And the electrodes can also be seen here in black. So you see the electrodes here, and the cells are plated on top. And there could be even several cells on the electrode. Again, you see this image, image again here. There are 12 electrodes here. Those are the black dots. And they're measuring the activity. And over time, we can see if the cells are firing, as we say it. Here again, these are the different electrodes, the different channels, as we also call them. And over time, we see those dashes. And when there is a dash, what we also call a spike, that means that a neuron is firing. If there are several neurons on one electrode, you see that there may be more neurons firing, and it could be if they're close together, then we call it a burst. So there are several of those dashes and spikes together. But as I said, those cells are heavily connected with each other, and there's a network. You can imagine that if a few cells are firing and very active, that via their connection, it's also influencing other cells in that complex network. And that maybe when some cells are firing, also the other neurons on the other electrodes also start to fire. And then we can have what we say a network burst. So the moment a few cells get active, the whole culture is becoming active. And this is what we call a little bit the raw data, but we can also now analyze it in a different way. So we had 3 control lines, control cultures, and 4 4H cultures from different patients. The controls are in grays and black, and the 4H in blue. And you can see that if you look at the spikes, so one fire activity or the burst, or there's several fire activities at the same time, or even when the whole network is bursting, that the activity all over in the 4H cultures is much higher for all the different patient lines. So yes, we also see that on functional network over time, that there's a difference and there is more activity. To go back to these, what we say, raw images, I showed you before the control images. So these are the different electrodes and the different spikes. So in this electrode, for example, there's no cells firing. Well, in this electrode, there are a lot of cells constantly firing. And you see a clear difference between the controls and the 4H cultures. In the 4H, you see clear, what we say, the burst network. So when in one electrode there is activity ongoing, also in the other electrodes you also see activity ongoing. And then to really see like what is going on, are there certain synapse types involved, certain cells can be studied. That what we quite often do is giving specific, what we say, agonists to stimulate certain synapses, certain connections, or even maybe inhibitors that can inhibit certain connections between cells. And I'm highlighting one here, which is when we're adding the antagonist to inhibit the GABA, so the inhibitory connections. And then you see that the control cultures are changing a lot. They also now start to show these typical bursts, these network bursts, that the culture really as a wave start to fire at the same time. You also see something changing in the 4H, but not very clear. So what we see is that when we add this inhibitor for GABA, there's not so much happening in the 4H cultures, but a lot in the control cultures, because in the controls, you just simply have more of those GABAergic synapses. So to conclude, we see increased activity in the 4H neuron cultures, but there is less inhibitory, less GABA activity in the 4H. So this data is in line with also the quantification of the synapses. So on two different levels, we now see in these culture types, in these cortical cultures, that the inhibitory activity is decreased with the kind of measurements. But there's still a lot of questions. And one of the other questions that we at least answered within this study is to see, are there certain interneurons that are more affected? And there are a lot of graphs here, so I'm sorry for that, but every graph is, let's say, representing one type of interneurons that we wanted to see. Are they changed in the expression profile? And I'm pointing out now the last graph here on the right bottom, that is ERBB4, and that's a marker for a progenitor state of the provalbumin interneurons. And there we see that the marker, or the numbers, are actually increased in 4H, which might be a little bit surprising, because before I was indicating that the GABA activity is down. But because this is a progenitor stage, we think that these provalbumin interneurons are kept in a more immature state, are not able to mature completely on like it is happening in the control cultures. And because they're not completely maturing, they are not able to give the same inhibitory activity as you see in the interneurons. So this is at least one indication that is pointing towards the provalbumin interneurons that might be affected in the 4H cultures. So it's more the development rather than the generation of these interneurons that may be affected in 4H. So we grouped all this data together, and in conclusion, in 4H we see decreased percentage of inhibitory synapses, but increased neuronal activity, less inhibitory activity, and we have some data pointing towards the provalbumin interneurons that are affected. And this data is now published, and we're very happy about it. And I'm immediately acknowledging all the co-authors that are really worked hard on it, and especially Dr. Wolf, who's also here on the call, who was a co-senior on this paper and this story. And very shortly, with a few slides only, I just want to highlight that the work that's also ongoing within a European consortium that started a few years ago. That's a collaboration within scientists and clinicians in different places within Europe, and also ELA is actively involved. And there we not only studying 4H syndrome, but also two other leukodystrophies, GLD and Canavan disease. And this gives the opportunity to not only study disease-specific mechanisms, but also to see, are there comparable mechanisms ongoing in several leukodystrophies, which could help to identify more general mechanisms, but also disease-specific mechanisms. And from there, in that consortium, we also use the patient iPSC technology, and for 4H also the same lines. And here we are creating also brain organoids that are typical for the cortex, so the cortical brain organoids, and you can see how long we keep the cells in culture, up to day 150, and at different time points we collect the cells and we analyze them again with imaging, also with electron microscopy. We're still waiting for the data, and we're also about to do bulk and single cell RNA sequencing. So I just want to highlight a few results to show that the data is about to come. So this is showing actually the ferrite diameter is actually diameter of the organoids. So we also over time measured the size of the organoids, and when we grouped all the organoids and the sizes together, we concluded, well, we do not see a size difference in the organoids. That's fine. That's also indicative that the cells were growing healthy. So, and we kept them under day 150. These are some examples of how the sections look at day 50 and here at day 100. And you can maybe see popping up some green dots. So that is the MBP protein, the myelin basic protein, that is indicative that the organoid structures are also maturing and that there are oligodendrocytes producing also myelin proteins, which is also enlarged here. So we're very happy that the organoid structures look overall healthy, that we can actually analyze it. So that's what we're doing now. We're quantifying all the different markers that are identifying astrocytes, neurons, oligodendrocytes in all these different patient lines and different controls, and also over time. So for example, for MBP, which is indicative for myelin protein, and that is what we know coming up later during development. You can see that at day 100, the myelin is really nicely coming up. I can't say anything yet about the differences between the different patient lines or between patient and controls. And this is the last slide just to indicate that we're about to do this gene expression profiling. That is what people more and more start to do in these organoid structures, where you have all kinds of neural cell types present. If you would do the analysis on the bulk, you might lose the subtle differences and the very important differences that you find in certain cell subtypes. So by taking the cells really apart, really create single cells, and then analyze the transcripts in all the different cell types, we hope to identify better different pathways and genes, gene dysregulations over time that maybe dysregulated in the different diseases. And we're actually expecting a lot of different data, and it's going to be a challenge, but very exciting to look at it to see if we can identify new things that we can follow up, and hopefully also to identify new drug targets. So this is really my last slide, and I really would like to acknowledge all the people who were involved in the first study, the researchers in the lab. Nicole was really important, Mariana Bucciani and Marlon Breuer for also identifying these mechanisms in human tissue, which I did not have time to show, and also all the members of the European consortium. I'm thanking you for your attention.
Thank you so much, Vivi. Fascinating data and really very promising model for this challenging leukodystrophy. Thank you. So the last speaker of this session is Dr. Noemi Hamilton from the UK. She is just moving from Sheffield to York and leads the UK Leukodystrophy Research Network, Leukolabs. She uses zebrafish, another model for leukodystrophies, so not mouse or human cells, but a small fish. So I'm sure we will hear more about it. Dr. Hamilton, please go ahead.
Thank you. Nicole, good afternoon, everyone. I'm going to share my screen. Yes, can everyone see this? Good. Thank you very much. So as Nicole said, my name is Noemi Hamilton. I am based in the UK, and it's a real honor to be here, to be able to share our work with you, with the ELA family and all the scientists present on the call today. So I am also not a clinician like Vivi. I am a biomedical researcher. And I'm also going to talk about a model, and it's our little tropical zebrafish. So I'll start with the story that has been mainly funded by ELA, and I'll finish with giving you some updates on what we're doing in the UK at the moment on the leukodystrophy front. So for this story, I thought I would start right from the start, which is 12 years ago when I was doing my PhD. Back then, I was in a cancer lab, and we used zebrafish to model chemotherapy resistance. And I screened many animals in a genetic screen to find animals that could help in identifying genes for chemotherapy resistance. And I found this mutant, the ribonuclease T2, or RNase T2 zebrafish mutant. And very quickly, we realized that it had nothing to do with cancer. And my supervisor at the time wanted me to drop it. But there was something so interesting in that fish. It used to light up like a fireworks when you use a lysosomal stain called acridine orange. And I did a little bit of work on the side, and I could see that it was the neurons that was specifically affected. They had very enlarged lysosomes. Every single one of the neurons nearly have one. You can see here they're dark, electron dense. And what we knew about RNase T2 at the time is that it degrades RNA in those lysosomes. So those little compartments in your cell that are supposed to being used like a bin, like a recycling bin, chewing up everything your cell doesn't need anymore, couldn't chew up RNA. And that was accumulating in those poor neurons. But what did that mean? I had no idea, and I was reaching the end of my PhD, and everything was starting to be quite stressful until this paper came out. And this is from a Utah Gardner's group in Göttingen. And in fact, in human, if you have RNase T2 mutation, you will develop a leukodystrophy. And I remember thinking, a what? What? I had to write this word down on a piece of paper to take it to my boss and tell him that we had the only animal model for this human disease. And suddenly things started to get a lot more exciting. And I quickly realized that there were very little models available in the leukodystrophy world back then. There are a little bit more now, but we had the first zebrafish model. And we kind of think that we sorted it out. What was happening in that disease was that this RNA accumulated in the cell, and this causes the organism to think it's being infected by a virus. And this is why in the patient too, they look like they are being infected by a brain virus. So what happens, this RNA accumulates in the cell and maybe starts damaging the neurons. So we decided that we needed quite a lot of help from different people. And this is when the collaborative angle of doing research starting in me is right during right during my PhD. So we asked the clinicians from a Utah Garner's group to help us out. So we pulled data from patient fibroblasts. We asked very specific technical people in the Netherlands to try to do MRI scans on our zebrafish to check their white matter. And of course, we use our wonderful zebrafish model, and we pulled all this together, and we managed to get a very nice publication. But what I want to show you today is how you can use this model. So we wanted to see, is there also a virus antiviral immune response in those fish, just like in the patients? And the answer is yes. So we found by looking at gene expression analysis that there is response to virus, immune response, very upregulated in the animals at different stages. So we use tiny little embryos, larvae, and then adult brains. And we can confirm this by looking at specific genes that are really upregulated when you get infected by a virus. So this ticked a big box. Our zebrafish model was mimicking what we were seeing in the patients. But then are they sick? Do they have the same symptoms as we can see in the patients? The answer is yes. So using our fixed brain MRI scans, we could see white matter lesions in the brain. These animals move less. They are hypomotile. They swim a lot less. They're even shy to explore the tanks. As you can see here, this is the mutant, whereas a healthy animal would go everywhere in a tank. And they have a decreased survival as well. And I'm going to show you a video here of what happens to these fish if you look at them swimming. I don't know if you can see the one that is tumbling down in the middle of the tank. It can't swim anymore. It can't find food by swimming like this, and it doesn't socialize with the other fish. So this is the severity limit at which we need to humanely kill this animal. So we knew quite a lot of things. This animal reproduced what we could see in the patients, and it had an immune response. But what about immune cells? This is what my lab is doing, is to look at immune cells in the brain. And we've talked a little bit about microglia today, but I thought I'll give you a little overview about these cells that really are the guardians of our brain. So they have three main functions. The first one is the sentinel. They're going to sense the brain, sense the environment, making sure that everything is okay. They are also very good house cleaners or housekeepers. They're going to hoover up, clean up the debris and the dead cells in our brain. And of course, they are also real soldiers. They defend our brain against virus infection, any kind of pathogen. And I wanted to know, what is the first role of a microglia in a developing brain? And it turns out that the main role of a microglia right at the start of brain development is the housekeeper. So I don't know if you know this, but when you make a brain in human, in mice, or in fish, the brain makes way too many neurons. And between 40 and 50% of those cells are being killed. They die by what we call neurodevelopmental apoptosis. And this happens across many different organisms. And it is believed, and it's been shown in fish, that this is the first signal that calls into the brain the macrophages that are being born, these healthy immune cells in the body. They're being made, and they are being called into the brain. Those macrophages reach the brain, start hoovering up all those dead cells and differentiate into microglia. So this is the first ever mission of those microglia, is going to the brain and clearing up all the dying neurons. And the zebrafish is transparent, is being born outside of his mothers, unlike humans and mice. So we can look at the brain right from the first day of development and look at this process. And if you look here, you can do videos, you can keep a zebrafish under the microscope for up to 20 hours, And you can see the difference. The microglia in the wild type are very elongated and dynamic, whereas in the RNase-T2 mutant, they bloated and they don't really move that much. They don't look very healthy. So our hypothesis from that moment onwards was, what if the first ever mission of those microglia is a total failure that could potentially cause the disease? And you could also think that this could be the case for RNase-T2, but it could be the case for other leukodystrophies. So with funding from ELA, this is what we did. We looked at those early stages. Everything I've shown you so far was adult assays, but we did all the live imaging to prove, in fact, that yes, those microglia in the RNase-T2 mutant are totally useless. They absolutely fail at doing that first mission in that brain, which is to clear away all those dying cells, which are here labeled in green. You can see the microglia in purple, very big. And we've shown this in multiple different assays. We did electron microscopy, we did live imaging, we did fixed imaging, and all of this is already published and summarized here on this slide. So as I said, I had a fellowship from ELA for 3 years to do all this work. And this is now the foundation of my research group. But very interestingly, what we found at the end of this project was that if you rescue the gene, so the RNase-T2 gene, only in the microglia in these animal models, you rescue these clinical symptoms, you rescue the phenotype, which made us believe that maybe the microglia are the drivers. They are the ones that are causing the disease because of that first ever mission right at the start of brain development that doesn't go right. And this is when I was very lucky to have Holly starting her PhD with me. And she wanted to develop a therapy to replace those pathological microglia. So when we think of methods to replace immune cells, obviously we think about bone marrow transplant. This is what's being done in many leukodystrophies and other diseases. But she wanted to take a shortcut. She only wanted to replace the microglia because this is what we showed, that the microglia, not the other immune cells, are responsible for the disease. So she developed a macrophage transplant. So she developed this by taking a healthy macrophage graft. These cells are labeled in GFP, so in green. The equivalent of the bone marrow in the zebrafish is the kidney. So this is where she gets her graft from. She isolates them, and then she injects them into the blood circulation of baby mutants, baby sick animals. And she does two different things. She conditions the animals, so she removes all the macrophages like you would before bone marrow transplant, or she doesn't. And then she compared what was happening. And those macrophages go to the brain. And once they go to the brain, they differentiate into microglia. So she can show this by using a marker that is specific for microglia, which is in purple here. And she saw a striking difference between animals that didn't have any macrophages at all. These transplanted macrophages go straight to the brain, which kind of makes sense because the niche is empty. The brain is really calling for these immune cells. So you can see when she depletes the animal from macrophages, she sees a lot more transplanted cells reaching the brain. So she continued these assays, and she wanted to know whether those transplanted macrophages, they look like microglia, they express microglia marker, but can they function like microglia? Can they perform that hoovering, clearing up function that they're supposed to do at that stage? So she has been looking at dying cells, the number of dying neurons in the brain. And that first square here is a healthy brain, which is not supposed to have many dying cells in the brain because that's the job of the microglia. So you can see that on her diagram here. And then if you remove all microglia from the brain, if you deplete them, then suddenly you get a higher number of dying neurons being left behind in the brain because no Hoover is available to remove them. But if you add healthy macrophages, suddenly that number goes down. And this is only 3 days after transplantation. So there is an improvement, there is a partial rescue of that number of apoptotic cells hanging around in the brain. And then she took this step further. She said, well, what if I weigh double the amount? So she did the same assay 6 days later. And then you can see that that fully rescued this phenotype that we had in the fish. There is as many cells as you have in a healthy brain, as many dying cells in a healthy brain. And then she asked, can this rescue the phenotype, the swimming, the behavior? And the answer to that is also yes. So when she looks at her 8-day-old fish, so 6 days after transplantation with healthy macrophages, those animals, she follows them with a camera swimming around the well. Suddenly they are not hypomotile anymore. They start moving as well as healthy animals. So what I'm showing you here is assays on embryos, larvae. We need to check this in adults. Can this therapeutic effect last? So to do this, she's developing some optical clearing because the zebrafish is beautifully transparent when they're babies, but the brain becomes opaque as they grow. So what she's been doing is clearing up those brains and labeling apoptotic cells, oligodendrocyte, we can label the myelin, and of course our transplanted cells. And now we are running all those assays to see whether the transplant has a therapeutic benefit over time. So those longitudinal studies are really important, obviously. So she is doing that beautiful clearing. And what I've developed in the past few years is I've showed you images of MRI on fixed brain. Actually, the head of the fish is chopped, and we do this on chopped heads. But I wanted to be able to check the brain of the fish throughout their life on the same animal. And for this, we had to find a way to keep a zebrafish happy and alive in an MRI scanner for 2 hours. So we've just published this, and now we can do this. We can have a zebrafish in an MRI scanner for a couple of hours to have a beautiful image of their brain that you can see here. Then we can take them out, let them swim a little bit, and then 3-4 months later, give them another MRI scanner. So this is good. We're very happy with this project, but I am a basic scientist and I want to have an impact on patients' life. So what happens? This is a very linear, easy way to cure a patient, but we all know that it doesn't really happen that way. It's really long, it's really difficult, it takes a lot of time, a lot of money, and a lot of people. The path to having a cure is very long. We need biomarkers, we need to find out the pathology mechanism, which is what we did here with our fish. We need to develop therapy, which is again what we did here with our fish. And then of course we need clinical trials. And all of this is what I call the road to impact. You discover something in the lab, in the clinics, but then you need to expand, you need to connect, you need to reach and engage with other people, all the stakeholders, the patient voice, the public, the network. You need to collaborate. And then those discoveries need to be applied, trial tested, change, optimized. And once you know that it's working, then you need to amplify it, have it widespread, not just in the US, not just in Europe, everywhere in the world. And to achieve this, obviously, my lab is down here in the discovery box, and we needed to move a step further. And we realized that a lot of people need to do this in the UK, in the leukodystrophy world. So we created a research network that we called Leukolabs. This network was created last year. We already had our first meeting back in November that ELA kindly presented to. And the two main goals of this network is to connect everybody, to start this communication, to try to share basic discovery research with clinical data, to make our basic research stronger and to be able to move clinical research further by being able to test therapies in animal models. And those models are coming from this pipeline that you can see on the screen here. I've shown you today what we've done with zebrafish, but we are doing the same with flies and with 3D brain organoids. And this is to be able to provide quick functional assays on all those rare new leukodystrophies that are being identified and that there is very, very little research being done on. So this is the vision of Leukolabs, like I said, is to connect, is to unite researchers and clinicians. And you can find this on our website. I will share with you the link later. But what I want to tell you is that last year, Leukolabs was not the only research efforts in leukodystrophy that happened. We had a big year in the UK on the leukodystrophy front. 2022, we're going to remember it. So Leukolabs was born. Everyone probably knows Alex TLC, our very strong patient voice that we have in the UK representing all patients. But we also had the first patient registry that has been created. And then the NHS, our health services, have finally created 7 centers, 4 for adults and 3 for children. So inherited white matter disorders, diagnostic and management services all across the country, which will now be able to look after patients and hopefully reduce this number of years that sometimes it takes to be able to be seen by a specialist. So please, if you need any more information, do email me. I've run over time. I want to thank everyone in my lab and all my mentors, Professor Laura Feltry and Professor Steve Renshaw, all the funders that have generously funded us over the past few years. And then if you want to find out more about Leukolabs, please, you can go on our website, you can contact me or our Leukolabs email address. Thank you very much for listening.
Thank you so much, Dr. Hamilton, for sharing your results. Beautiful zebrafish MRIs. That's really fascinating. And also the fact that you can transplant these fish is fascinating. And also good to hear that the leukodystrophy field in the UK is getting organized. So that's a great news for the patients there. Thank you. So I think there are some questions in the chat. I answered some individual questions already during the different talks. There is a question how you can sign up for a white matter disease clinic in the UK.
Should I try to answer this? Georgia, thank you for this. You're right. The Manchester Leeds Center, I don't know where you live, but it is the northern center. So the website is live as of, I think, 3 weeks ago. So maybe if you try again, otherwise, if you email me, I can give you the name of the person in charge of the Leeds clinic, which will be able to give you all the details from the Manchester people.
Maybe we could take a question from the audience. There is a hand that I can answer. It's Oren Mystery, if you'd like to ask your question. You can activate your microphone and ask your question. Aaron? No, he's not taking. So if anyone would like to ask a question, please raise your hand on your computer and we will be able to give you the possibility to talk. All right, so we have Marie-Isabelle. Please activate your microphone.
M'entendez?
Tout à fait.
Bonjour, vous m'entendez, oui?
Can you hear me?
Oui, on vous entend.
We can hear you, madam. We can hear you loud and clear. I have a question, not specific to leukodystrophy. I have been a member of ELA for probably 7 or 8 years. Initially, we met Mrs. Bofun-Tanguy, who told us that Tatiana, our daughter, probably had leukodystrophy. I actually wrote this earlier in the chat, but nobody answered me. So Tatiana today was diagnosed. She got diagnosed by Geneviève Bernard, whom I'm doing a conference. She has spastic paraplegia, and I've been reading all the clinical tests she's done. Initially, it says that it interferes with her walking. Then she also developed cramps during the night. She also has a pyramidal axial symptom. She has white matter, which is increasing. And so I wanted to know, is there any specific research in this area? And what hospitals exist in France that could specifically help her? I think for my eldest daughter, it's probably too late. She's now fully dependent. She's lost a lot of her cognitive function as well. But we have a granddaughter, 11-year-old, who is probably carrying the genes. And then my other daughter, who is 30 and who doesn't wish to have children because she's afraid she could pass it on. So I don't know if you have any answers to my question.
Merci de votre question. C'est quoi le diagnostic exact chez votre fille?
So what is so it's spastic paraplegia, STG15, type STG15.
Sinon, en termes de, parce que j'ai l'étude sous les yeux, c'est donc le ZFYV26,
26
FYVE,
5FYVE, protein 26. Gene is associated with spastic paraplegia 15. She's reading in English.
Merci. Donc, c'est une maladie récessive.
Okay, so this is a recessive disease, which means that your daughter is carrying the gene. And you mentioned your granddaughter.
Non, pas la maladie.
She's not carrying the disease. No.
Vous êtes porteuse vous aussi, très probablement.
You probably have the gene.
Ça vient de la mère.
Yes, it comes from the mother, and the father has another disorder. Okay, right. So that's the mechanism with recessive diseases. Now, as far as expertise centers,
HSPs, je vais
hold on, let me
voir s'il y a un centre en France.
I'm going to see if there is a center in France. I think there is one.
So, France. Oui, ça devrait être le Pitié-Salpêtrière à Paris.
Right. So according to my information here, it should be the Pitié-Salpêtrière Hospital in Paris.
On les a vus plusieurs fois, mais ils
Okay,
proposent
well,
strictement rien. Il y
we
a
talked
pas
to
de
them several times,
traitement,
but
il
they
y a,
really have
il y a même
no
plus de
treatments to offer.
rendez-vous, il y a, enfin,
You
c'est-
can't even
il y a
take an
aucun
appointment
suivi.
anymore. There is no follow-up, patient follow-up available.
Ja, c'est très difficile de commenter ce problème-là. Et
I know
je ne crois pas
it's
qu'on peut trouver une solution.
complicated. I
Mais
don't think we
le
can
pôle
find
expertise
a solution at
pour
this
les
point. But
paraplégie spastique héréditaire, c'est
for-
Pitié-Salpêtrière.
all I know is that for this
Merci de votre
pathology,
réponse.
normally it should be the Pitié-Salpêtrière
Bonne
Hospital.
fin de journée. Au
Okay, thank you very much for your answer. Thank you so much.
Il n'y a pas d'autres mains levées pour le moment.
My understanding is that there are no
If
further
anyone wants to
at
ask a
this
question,
point.
please raise your hand.